Good evening, everyone, and welcome to the fourth and final session of Research Day. My name is Dr. Darbrielle Hunt Burrows. I am the head of Department of Internal Medicine and also a member of the academic faculty of the University of Clinical Medicine and Research as a clinical tutor. I will be your moderator for today's session, which is the second featuring of community medicine and also internal medicine. We have been so greatly enriched so far by the great presentations and research. For those of you who have not been able to join these sessions so far, they will continue to be accessible via the Sunshine Learning site. Tonight's sessions are also promising to be very, very informative. I hope that you will be inspired. And without further ado, we will continue into the presentations. Please note the feedback link, and that is, if you'll notice, it's in the chat. We are going to go directly into the residents' presentations. And so our first presenter tonight will be Dr. Hilary DeVoe, who is a member of the Department of Medicine. Dr. DeVoe has been a very, very integral member of our COVID team. He has given significant service to the COVID team, and that has significantly contributed to his ability to add to the research that he is going to present. Dr. DeVoe tonight is going to be presenting a paper on vaccination status of COVID-19 hospital admissions and COVID-19 deaths at Princess Margaret Hospital, March 14th, 2021 to September 30th, 2021. Dr. Hilary DeVoe.
All right. Thank you, Dr. Hunt. Okay. There we go. Can everyone see the slides?
Yeah.
Okay. All right. Good evening. So I'll be presenting on the research that we've been doing, which looks at SARS-CoV-2 vaccination status of laboratory-confirmed COVID-19 hospitalizations and COVID-19 deaths at PMH between March 14th and September 30th, 2021. All right, I have no disclosures. This is the basic outline we're going to follow. Now, coronavirus disease 2019 is defined as an illness caused by the novel coronavirus called severe acute respiratory syndrome coronavirus 2, which was subsequently termed COVID-19 by the WHO. It was first identified amid an outbreak of respiratory illness cases in Wuhan, China, initially reported to the WHO on December 31st, 2019, and declared a global health emergency January 30th, 2020, and subsequently declared a global pandemic on March 11th, 2020. Now, as of October 27th, there have been almost 245 million confirmed cases of COVID-19, almost 5 million COVID-19 deaths, and almost 6.7 billion vaccine doses have been administered worldwide. Since the beginning of the pandemic in the Bahamas in March 2020 up to the 27th of October 2021, there have been 22,351 laboratory-confirmed COVID-19 cases, the majority in New Providence, followed by Grand Bahama, and 643 documented COVID deaths. Since the rollout of the vaccination platform on March 14th, 2021, there have been 127,567 people that have been fully vaccinated, which is roughly just under 30% of the population. Now, since the COVID-19 vaccines became available under emergency use authorization, starting with the Pfizer vaccine on December 11, 2020, followed by Moderna, then AstraZeneca, and then Johnson & Johnson. Many vaccines for COVID-19 are now currently available worldwide with the advent of various vaccine rollout programs. However, this has slowed due to the vaccine hesitancy, resistance, and misinformation. Vaccines have been shown to be highly efficacious in clinical trials and in the real world to reduce transmission, hospitalization, and deaths. And in the Bahamas, with the rollout of the vaccine platform with AstraZeneca first on March 14th, followed by Pfizer and Johnson & Johnson on August 16th. Vaccine hesitancy, mistrust, false information continue to undermine our efforts to vaccinate the Bahamian population, as we noticed that during this period of time when vaccines became readily available, COVID-19 admissions continued to soar. And in fact, there were reports within the community of various locations about breakthrough infections and deaths in fully vaccinated patients. This led to our study, which we looked to describe the SARS-CoV-2 vaccination status, clinical and demographic information among patients hospitalized for COVID-19 and dying from COVID-19 at PMH. We reviewed all COVID-19 hospitalizations between March 14th and September 30th, 2021, and included all patients with laboratory confirmed COVID-19 via rapid antigen or PCR. We categorized admissions and deaths based on vaccination status as defined by the WHO, meaning we had patients who were non-vaccinated, partially vaccinated, meaning more than 14 days past their first dose, and less than 14 days after the second dose in a 2-dose vaccine series, which was inclusive of Pfizer and AstraZeneca, or less than 14 days after the receipt of the Johnson & Johnson vaccine, or fully vaccinated patients who were vaccinated more than 14 days past their second dose, or in a 2-dose series, or first dose of the Johnson & Johnson vaccine. We compiled additional information, demographics, sex, age, and comorbidities, and excluded non-COVID-19 deaths. All statistical analysis was performed using the SPSS software, version 27. Pearson correlation analysis was used to determine relationships between variables and logistic regression to determine predictors of death among subgroups. And significance level for all analyses was set at a p-value less than 0.05. So we had 1,001 COVID-19 admissions with an average age of 56 years and standard deviation of 17, and 55% of those admissions were female. There were, well, as shown in the pie chart, the majority of admissions were severe cases, accounting for 72% of all admissions, which was 722 patients. Now, we classified patients based on symptom severity using the WHO severity definitions. Initially using the case definition for COVID-19, which was acute onset of fever and cough, or acute onset of 3 or more of the following signs: fever, cough, general weakness, headache, myalgia, sore throat, dyspnea, anorexia, nausea, vomiting, diarrhea, altered mental status. So patients with mild COVID were symptomatic, meeting the case definition for COVID-19, but without evidence of viral pneumonia or hypoxia. Moderate COVID were patients with clinical signs of pneumonia, fever, cough, dyspnea, but no signs of severe pneumonia. And severe COVID were patients with an oxygen saturation of less than 90% on room air, a respiratory rate greater than 30 breaths per minute, or signs of severe respiratory distress, including accessory muscle use and inability to complete full sentences. The majority of patients admitted to the COVID unit were unvaccinated, making roughly 96% of the patient population as seen in the bar chart. And as time progressed from the vaccine rollout period and the Delta variant became more endemic, more patients who were fully and partially vaccinated were admitted. However, the vast majority of patients admitted continued to be unvaccinated. So we can see based on the bar chart, the majority of patients admitted per month were definitely unvaccinated patients. However, as the Delta variant became more endemic, we saw more admissions that were partially and fully vaccinated. Now, the majority of COVID-19 deaths in total were 226 COVID deaths were attributed to patients with severe COVID-19 disease. So 99% of patients who died as a result of COVID-19 had severe COVID disease. And almost 95% of COVID-19 deaths were attributed to patients that were unvaccinated. Now, this figure shows the correlation between death and vaccination status by age group. And as we can see, the majority of death comes from those who were unvaccinated, the largest group being the 41 to 64 age group, which was the largest number of admissions, followed by the next largest age cohort, the greater than 65 age group. Now, partially vaccinated and fully vaccinated patients in any age group counted for less than 5% of all COVID-19 deaths. And in ranking order, partially vaccinated patients 41 to 64 years old were the largest group of COVID deaths, followed by the fully vaccinated 65 and above age group, then the fully vaccinated 41 to 64 age group, followed by the partially vaccinated 65 and above age group. There were no admitted patients during this study period that were less than 40 years old who were fully or partially vaccinated. Now, the AstraZeneca vaccine was the most common vaccine among admitted patients. This was expected as this was the only vaccine available between March 14th and August 16th until Pfizer and Johnson & Johnson became available. And the majority of patients admitted had at least one comorbidity. Almost 35% of patients had one comorbidity, where roughly 30% had two, 27% had no comorbidities. And the table on the right shows the comorbidities that we assessed or looked for. Now, looking at the correlations between comorbidities and risk of COVID-19 death, there were only two significant correlations that could be made. A statistically significant higher risk of death from COVID-19 was seen in patients with severe COVID-19 and in patients with malignancy. So patients with severe COVID-19 had an almost threefold increased risk of dying from COVID-19 with an odds ratio of 2.786 and a confidence interval from 1.05 to 3.98. And the p-value for this was 0. Whereas patients with malignancy had a six-fold increased risk in dying from COVID-19 with an odds ratio of 6.25 and confidence interval between 1.125 to 34.7 and a p-value of 0.36. Now, given our data shows that the majority of patients who were admitted had severe COVID-19 and also expired were unvaccinated, one would expect there to be a significant correlation between vaccination status and COVID-19 death. However, this was not the case. While there was a twofold increased risk in death from COVID-19 for patients with severe COVID disease, this was not statistically significant. So, essentially, our findings correlate directly with the international experience. In the US, the SCOBY study pretty much said that getting vaccinated protects against severe illness from COVID-19, including the Delta variant. And they looked between April 4th and July 17th, 2021 in 13 jurisdictions or states. And what they found was that more than 90% of COVID-19 cases, hospitalizations, and death were reported among unvaccinated patients, whereas 8% of cases, hospitalization, and death were reported among fully vaccinated patients. Now, while there was decreased vaccine efficacy against confirmed infection, there was not decreased vaccine efficacy against hospitalization or death from COVID-19. And within each age group looked at, the percentage of vaccinated persons among cases, hospitalizations, and deaths increased as the Delta variant became more prevalent. However, unvaccinated cases were significantly more predominant. The Griffin study also in the US found that fully vaccinated persons aged 16 years and older with COVID-19 infection were less likely than unvaccinated persons to be hospitalized, admitted to the ICU, require mechanical ventilation, or die from COVID-19 infection during a period when the Delta variant became predominant. And this study looked between dates of May 1st to July 25th and found that 71% of their patient population were unvaccinated, 25% were actually fully vaccinated, and 3.3% were partially vaccinated. And infection and hospitalization rates among unvaccinated persons were 4.9 and 29.2 times higher, respectively, than those in fully vaccinated persons. And the graph on the right essentially is showing that whereas the Delta variant became more endemic within the population, you had an increase in number of patients infected and admitted, be it unvaccinated, partially vaccinated, or fully vaccinated. However, the unvaccinated population was significantly more infected than the other two cohorts. In the UK, the Akbuchi trial. Over 51,000 COVID-related deaths, found that there were 0.5% were breakthrough deaths, meaning fully vaccinated patients. And vaccination reduced the odds of in-hospital mortality, although immunocompromised patients in the study had persistently high risk of mortality after both the first and second dose of the vaccines. And most patients admitted to hospital with COVID-19 after the 16th of June were in fact fully vaccinated. However, the study says this was expected given the high rate of vaccine uptake and a policy of vaccinating higher risk people first. However, by August, the rate of hospital admissions and deaths from COVID remained substantially greater in unvaccinated than in vaccinated people. Between August to September, the rate of hospital admissions for patients over 80 was 50.5 per 100,000 in the fully vaccinated group, where it was more than double in the unvaccinated group. And the same thing can be said for COVID-19 deaths in the over 80s, where 45.5 per 100,000 died, and this was almost tripled in the unvaccinated population. And in Scotland, the SEEK study, which found in their study population, 99% of patients had the Delta variant, but these were mostly unvaccinated patients, younger patients with fewer comorbidities. And looking based on age, those less than 40, those who were fully vaccinated, there were no deaths. Those who were unvaccinated, there were 17 deaths. And looking greater than the ages of 40 at vaccine effectiveness against death from COVID-19, both vaccines that were studied, the AstraZeneca and Pfizer vaccine, were more than 88% effective in preventing death from COVID-19. And lastly, in France, a study that was done between December 2020 and July 2021, which covered vaccination with Pfizer, Moderna, and AstraZeneca. It involved 22 million vaccinated people greater than the age of 50. And it showed that in both cohorts, ages 50 to 74 and greater than 75, the majority of patients received the Pfizer vaccine, followed by AstraZeneca and Moderna. And it showed that there was a reduction in risk of hospitalization from the 14th day after the injection of the second dose, greater than 90% in both cohorts and for each vaccine. And this reduction is the same order of magnitude for the risk of death during hospitalizations for COVID-19. And the effectiveness of vaccination on severe forms of COVID-19 did not seem to decrease over the available follow-up period, which went up to 5 months. So the cohort age 75 and older, the vaccine was more than 94% effective at 5 months for Pfizer, and 97% between the 50 to 74-year-old cohort at 4 months follow-up. However, unfortunately for the Moderna and AstraZeneca vaccines, the follow-up was too short to be able to study their effect at 4 or 5 months. Right. So in conclusion, what our studies and most studies internationally now showing is that vaccines work. They're not 100% effective, but they significantly reduce risk of severe illness, hospitalization, and death. And there is need for a widespread educational campaign on vaccine effectiveness to combat hesitancy, resistance, and misinformation. Now, recent studies are showing that COVID-19 vaccine efficacy against infection rates are waning 6 months after being fully vaccinated, which has prompted many regulatory bodies to now recommend booster doses for significantly at-risk patients. So those who are immunocompromised or patients who would be considered very high risk. However, vaccine efficacy remains robust to prevent the majority of severe COVID-19 cases, hospitalizations, and deaths. So these are my references. Thank you.
Dr. DeVoe, thank you for this presentation. Thank you for all of the work that you have done on the ground with these patients. It certainly will contribute much to patient care. Does anybody have any questions for Dr. DeVoe? We have any questions for Dr. DeVoe?
Hi, good evening, Dr. Hunt Burrows. It's Dr. Black. Can I ask a question?
Yes, please.
Yes, thank you very much, Dr. DeVoe, for that wonderful presentation. And yes, thank you very much for all the work that you've been doing on the ground. From the patients that you saw, were you able to find out in questioning them what was the biggest reason for vaccine hesitancy?
So I'll be honest with you, when vaccines came out, the majority of patients, once we asked them, because everyone is asked, did you get the vaccine? If they said no, we usually ask why. They said, one, because it's too soon, it's too early. They thought that the vaccine came out too fast. And they really didn't trust the information that they were being given, or they weren't trusting who was giving them the information. They're more inclined to believe what they might have been seeing on social media. They would say that, yes, the vaccine they talked about the microchips, that sort of stuff as well. And that they didn't want to put anything else foreign in their body, is what a lot of patients were saying. Essentially what's been happening though is that as patients who are admitted who haven't been vaccinated, once they display all these severe symptoms, have to be admitted, they actually turn around fairly quickly and ask if they can get the vaccine, just given how severe their symptoms have been.
Okay, thank you.
Do we have one more question for Dr. DeVoe? We'll be able to have one more.
I have a question, Dr. Hunt.
Yes, thank you.
Dr. DeVoe, I have called you on so many occasions to see our patients in OBGYN, and we are indeed grateful. So it seems as if the general public seem to relay and trust more other individuals from the general public. And so do you think that it would be useful to utilize persons who were significantly affected by COVID-19 to reach the general public? Because it seems as if they are not trusting our physicians or other health authorities or politicians. So how do you think we can actually reach the public?
Oh, most definitely. So we've had a lot of, I would consider, high profile patients or local celebrities who have been affected with COVID-19. And once they're discharged and they start to share their experience, people start to realize how significant COVID-19 can affect someone. And it definitely would be beneficial rather than, while listening from physicians and other qualified people about getting the vaccine and why it's important, it would be beneficial to have a lot of these local celebrities or people with a lot of influence start to advocate for vaccination. And I know that there was a segment where I believe one of the news broadcasters actually went into one of the COVID tents and interviewed a few patients. And I've seen several people significantly respond to that, where they can actually see how patients are suffering, they get their perspective, and it has changed a lot of people's minds to get vaccinated.
Thank you.
Thank you, Dr. DeVoe. At this time, we will go into the presentation.
Sorry, Dr. Baru, I
I'm
just
sorry.
had a one quick question. I typed in the chat.
The question from Dr. Varunda. Thank you, Dr. Varunda. Dr. Varunda's question, there were more deaths in females. Is that statistic true for admissions as well?
Yes, it is. It also is true for, so there were more female admissions and more females dying from COVID-19. More females actually were coming in with severe COVID symptoms. Yeah, that's pretty much it.
Once again, thank you, Dr. Hilary DeVoe, for an excellent presentation. At this time, we will go into our first keynote presentation, and this will be a presentation by our representative from PAHO. This presentation will be on the subject of the impact of the COVID-19 pandemic on non-communicable diseases in the Caribbean. And our presenter this evening will be Dr. Keva Thompson. Dr. Keva Thompson is our consultant on non-communicable diseases and mental health at the Pan American Health Organization in Nassau. And at this time, we welcome Dr. Thompson. Thank you, Dr. Thompson.
Thank you, everyone, and thanks for having me. Let's jump in. So the established outline for this presentation is stated here. We're going to look at the state of play for COVID-19 pre-pandemic. We want to take a look at the burden of diseases in the Caribbean. We'll meander around the interplay between NCDs and COVID-19, and then we go into a WHO survey known as the WHO National Pulse Survey, Continuity of Essential Health Services during the COVID-19 pandemic. So if we look at the burden of disease globally, we find that in 2015, we found 41 million deaths, 71 of which were attributable to NCDs, and 15 million of those, or 37%, were premature death. And for those who don't know what premature death is, it's loosely defined as unfulfilled death expectancy, and it happens in individuals between the ages of 30 and 70. In the region of the Americas in 2018, there were 5.5 million deaths. 81% of those were attributable to NCDs, and 39% of those were premature deaths. Bringing it a little closer to the Caribbean, we reported around 52,000 deaths in 2016. 77% of those were attributable to NCDs. 38% of those were premature deaths. And you find that 77% of all NCD deaths are attributable to the big five. That's cardiovascular disease, cancer, diabetes, respiratory disease, and other NCDs. So when we look at, or if we take a closer look at the risk of dying prematurely due to the four main NCDs, we find in the region of the Americas, the Caribbean is out front. Starting with Haiti at 31%, Guyana at 29%, Grenada at 23%, Suriname 22.7%, St. Vincent and the Grenadines at 20.7%, the Bahamas at 19.9%, and the Dominican Republic at 19.1%. So you find that in the Caribbean, your risk of dying prematurely due to NCDs is greater than most, and as we go down, we see even further that the Caribbean is dominating the risk of dying prematurely due to NCDs. So we come to a point in time in 2019, and we find that there is significant underinvestment or chronic underinvestment in prevention, early diagnosis, treatment, screening, and rehabilitation of NCDs. And so the WHO would have concluded that in 2019, systems were unable to fully respond. And if you look down at the percentages below, we had of the countries in the World Health Organization, only 34% reported providing drug therapy and counseling services to prevent and treat heart attacks and stroke. Only 40% of those countries reported having palliative care generally available. 48% of those countries having guidelines, existing guidelines for the 4 major NCDs. Only 62% of those countries have early detection programs for cervical cancer, and only 62% of countries having radiotherapy services for cancer treatment. And enrolls COVID-19. On March 11th, as my colleague before would have noted, we would have declared COVID-19 a pandemic. And since that time, as a country, as a health sector, we began repurposing health workers. We canceled elective surgeries. We closed outpatient services. There were reports of insufficient PPEs. There were changes in treatment protocols and policies. And all of this together have significantly impacted the delivery of services, health services in country and indeed in the world. Additionally, we find that there were changes in health-seeking behavior, and this is going to be key. We had constrained access to the hospitals and the healthcare centers. There was financial hardship, so people lost their insurance status. And all of these are significant barriers to health services. And so what does that mean? So despite the considerable progress, because I do need to note that between 2000 and 2010, there was a push towards improving prevention, treatment of NCDs. But around 2010, the momentum dwindled. And so by that point, SDG 3.4, which speaks to NCDs, was at risk, And we saw for diabetes, premature death had increased. And so we found ourselves around 2019 where there was underinvestment in prevention, early diagnosis, screening, treatment, and rehab. And again, the health systems were unable to respond. And you see the little purple bar where we're saying pretty much we were out of juice. And so 2020 found us with this disruption in the services. And so long-term upsurges in debt from NCDs were likely. Since the outbreak, people with NCDs, as stated before, were more vulnerable to becoming severely ill and dying. And today, the world finds itself at a critical junction. And so the execution of a forward-looking strategy must be inclusive of NCDs. And if and when we build back, or should I say when we build back, we must build back better if we are going to achieve SDG 3.4. Moving along, we want to take a quick look around, and my colleague did an excellent job of kind of talking to you about the interplay between COVID-19 and NCDs. And the interplay between these two reveals different effects. So there are both direct and they're indirect. The direct, we note that comorbidities are directly linked to severe COVID, hospitalizations, and death. Now, the indirect is a little bit more difficult to measure. And we'll note that, as we stated before, we note that people are resistant or unwilling to utilize our services. And so that could result in delays in diagnosis for more acute conditions. So Dr. Wells is in the room, so she may be seeing more persons delaying AMI. People are skipping their screening appointments because they don't want to go to the services. People are, and the health services now have protracted wait lists for diagnostics and some procedures. And so all of this together is wreaking havoc on the lives of persons living with NCDs. Turning back to the data, we find that in the Americas, there are some 250 million individuals at increased risk to severe COVID disease. And those are persons with at least one condition, one NCD. In Latin America, you note that that number looks more like 22%, but in the non-Latin Caribbean, our numbers are 29%. And if you jump down to the table below, you see the teasing out. Dr. Varunda would have asked about gender. You see males having a risk for one condition. Males have a risk of 17%, and females having a risk of 19%. And when we look at 2 or more conditions, we find that males had a risk of 5% and females had a risk of 8%. So Dr. Varunda, there are already gender differences in the risk of severe COVID diseases, and we saw it playing out in Dr. DeVoe's research. Moving forward, CARICOM would have taken a look at all of their inhabitants, and there are some 18.7 million of us living in the CARICOM region, and 5.4 million of us, or 29% of us, have at least one underlying condition, and therefore at risk for more severe COVID-19. And then we have persons who are over the age of 60 experiencing more severe disease as the likelihood of developing multiple comorbidities increase. We have individuals that are at working age, and those are persons between 15 and 64, also vulnerable, as 34.7% of us live with at least one or more comorbid conditions. And so this data is kind of explaining what that risk was, and we saw it play out in Dr. DeVoe's research. So he did my homework, he did my work for me. So I'm going to speed through a lot of this background and talk to you now about over a year, there has been, over the year, almost 2 years of COVID-19 pandemic, there have been substantial disruptions in essential services, and it persists across the world and indeed the region. And there are variations in the way countries have disrupted their services or try to re-engage. And so let's take a look at that, utilizing the World Health Survey. Again, it's the National Pulse Survey, looking at continuity of essential health services. And the focus of this presentation is on round 2. Round 2 would have covered February to March of this year. Round 1 would have looked at May of 2020. And WHO sought to gain a snapshot of changes, challenges in service delivery and utilization. And to my right, you would see the potential limitations. So this is a self-report survey. We attempted to collect information from a number of key focal points in the Ministry of Health around the world. And for this survey, some 54 countries were sent the survey. And if you look, you see questions were asked around policy and planning, strategic change to service delivery and public health activities, disruptions to tracer services, and those tracer services may be outpatient services, community-based services, health promotion, other surveillance activity, emergency referrals, and visits for non-specific symptoms. The reasons for the disruption were sought, mitigation strategies, information tracking, and country priorities and needs. And so let's dig into that. But let's start there. So I kind of cheated and I told you the results at the beginning of my discussion. And I want to tell you that of the 54 countries that responded to this survey, 16 or 30% completely filled it out. And it was a pretty extensive survey. 29 gave us partial answers. And so if we go through the section, we had 25 countries responding to health system functioning. We had 29 responding to maternal and child health and nutrition services, 23 to immunization, HIV, 22 countries, tuberculosis, 23, malaria, 11, neglected tropical diseases, 11, communicable disease 28, and non-communicable disease 27. So disruptions to essential health services are still widespread, as we stated before, across the region and indeed across the world. 46% of evaluated services presented some level of interruptions. So when we look at the graph, we see mild being 23%, and that's the yellow. Moderate, the orange, at around 14, and this is globally, and 9%, the red, being the severe. 97 of countries that responded to the survey reported that there was disruption in the provision of at least one essential service, and 45% of countries reported 50 to 70% of their health services suffered disruption. So if we go back to the graph, I tried to drop a red bar over the Bahamas and a green bar, not in this slide, over Jamaica, just to give you a sense for what was happening in these two countries. And so in the Bahamas, you see that we reported mostly mild disruption, some moderate disruption, and very little severe disruptions. Okay, moving forward, we find that the level of disruption for essential health services in the region of the Americas, and that's the 29 countries, the largest disruption was reported in the Andean region, and that was around, I believe, 60%. And in the non-Latin Caribbean, it was around 46% globally for us in the non-Latin Caribbean. Again, the yellow is mild, the orange is moderate, the red is severe. And of course, I do need to state that within countries, and as we move from round 1 to round 2, there were variations, and we'll get into that in a minute. So when we look at primary care and rehabilitation, palliative care, where there was palliative care, long-term care, these are the areas that are predominantly affected. So 55% of the 20 countries reported disruption in essential primary care. 40% of the 15 countries reported disruptions in rehab, palliative, and long-term care. And the likely implication here is for the more vulnerable population, such as older persons living with chronic diseases and disability. So half of the disruptions were reported across all services. So half of countries reported disrupted services for mental health, neurological, and substance use disorders at around 60%, and 55% for immunization. I want you to turn your attention to the graph, and you see, when you look at this graph, you see that NCDs, and I can't see it because I'm looking at myself there, NCDs reflected around 41% of the NCD services were disrupted. So disrupted services for NCD. So we tease that out at 41%, and we find the biggest services that were disrupted during COVID-19 was cancer treatment. And I'm wondering if any of my oncologists are in the room. Followed by hypertension, followed by urgent dental care, diabetes and diabetic complications, asthma, cancer treatment. I don't know why there are 2 cancer treatment. I might need to take another look at this slide, and cardiovascular emergencies. Service disruptions were due to a mix of supply side and demand side. So health workforce related issues were the most reported supply side reason for disruptions. Cancellation of elective care and changes in treatment policies were also reported. And you can see that in the slide. Most of the demand side reasons included community fear and mistrust, travel restrictions, hindering access to health facilities, and decreases in outpatient volumes due to patients not presenting. And on the supply side, there were also disruptions in 30% of the countries. And those include insufficient PPEs or closure of services. To some extent, disruptions may be attributable to intentional scaling back or modification of the delivery services in the context. And you note that half or more countries have limited or suspended outpatient care. And everyone in the room remember when that note came out that we were suspending outpatient care. And so 60% of countries reported suspending or limiting access to outpatient care, 58% to inpatient care, 58%, 40% to mobile clinic where applicable, 32%, and this is just limiting. And when we look at full suspension, those were attributable to mobile clinic and community-based care. Okay, so nearly half of the countries scaled back at least one essential services. And so almost 2/3 of countries had limited population-based services for disease prevention, with a small percentage reporting full suspension. 55 public health research, and this was one of the big things that were noted globally. 48 for health protection, 44% for health promotion, 33% for social mobilization. And the final graph I can't see, so sorry guys. So why do we care about all of this? So we're tracking the situation because if the interruptions persisted since 2020 with slight increases or decreases in some priority areas, we should see changes in our disease profile. And so we note that notable changes in the percentage of countries reporting any disruption from year to year or from round to round. So remember, round 1 was in 2020 and round 2 was in 2022. So the Bahamas would have noted in 2020 I believe that was a 35% disruption in the 35 tracer services that we mentioned. And when we move to 2022, the Bahamas would have recorded above average, somewhere around 65% increase, or sorry, disruption in services. And then you note, and if you want to think about the timeline, remember somewhere this covers 3 months between March to March of this year. And so I believe that the second surge impacted the amount of disruptions that would have happened. And so that's why we see differences in countries responding. So if we look at the green bar, we see Jamaica in the first round in 2020, Jamaica would have closed their services or disrupted their services at around 80%. And then in the next year, this year, it dropped down to somewhere around 33%. So from country to country, there were changes, but globally, there was minimal notable differences, if that's clear. So the average percent of countries reporting disruption varied by tracer services, as we stated using the example for the Bahamas. But I want you to turn your attention to NCDs specifically, and that's highlighted by the red bar. In round 1, 42, there was partial disruptions for 40% of the countries and around 22 severe disruptions. When we moved to round 2, and that's this year, there was 26% disruption. So we pivoted and there were less countries having partial disruptions, but more countries reporting severe disruptions. And so fewer countries were reporting disruptions in rehab and palliative services, followed by mental health and neurological services. More countries are reporting disruptions to reproductive health, maternal and child health, neonatal, adolescent services, immunization, as well as communicable diseases. And this is a mouthful. I promise that there is another place in time we can flesh this out and talk about what this means, because this is a lot of information. So some decreases in countries reporting disruption to NCD services were noted since the first round, and these decreases were small. And so if you look specifically at cancer screening and diabetes management, there were still substantial changes. So that's the first, well, cancer diagnosis would be the first bar and diabetes would be the second. And so you could conceivably conclude that individuals living with cancer or hoping to be diagnosed with cancer experience some pain and suffering because we had severe disruption of services. And I note that the Cancer Society reported sometime this week or last week that they're seeing an uptick in individuals with breast cancer, diagnosis of breast cancer. And so that is that's something we need to take note of in the Bahamas. So staff deployment provided COVID-19 response and insufficient staff availability continue to be the main reasons for disruptions. So recall at the beginning, we talked about how we repurpose staff. So the decrease in outpatient volumes due to patients not presenting. So if you look at round one, we had a bigger number of decreases than round two. So decrease in inpatient volumes in round one last year, decreases in inpatient volumes were greater and it went down this year. So we see where countries were trying to pivot, but we kept having, the surges. So it differs from country to country depending on when they saw their surge 2 or their surge 3. So most countries are applying mitigation strategies, as I started to speak about, to maintain the continuity of essential services. And here are 3 of the big things that countries reported. 92% of countries have defined what an essential service is, because what we found in 2020, some countries were not exactly able to elucidate what they considered an essential service is. And this year we see 92% of countries saying, we know what it is, we've defined it, we have a plan to move forward. 83% have designated a national focal point whose job it is to ensure that these services have minimal disruption. And 63% have attempted to change the funding for these services to ensure they continue. So the recommended strategies to restore or adapt service delivery that were implemented, 80% of countries reported using triaging to identify national priorities, followed by provision of home-based care. And in some countries we got some novel strategies for our supply chain. We expanded, some countries expanded the facility's hours. Some countries came up with novel strategies for refilling prescriptions. I take note that Princess Margaret Hospital had a WhatsApp strategy for persons to say, hey, I need a refill. And so countries, this is a learning process for all of us. And so countries started to pivot and use other strategies to ensure that their clients receive the care that they need. And one of the other big ones that we saw globally was the deployment of telemedicine. And in this country, we note that family medicine and psychology and some of the other areas would have rolled out telemedicine strategies to ensure that clients receive the care that they need. So many countries, so let's go back to the telemedicine issue. Many countries are using telehealth and technologies to mitigate disruptions. And you see where telemedicine or telehealth is being deployed for primary care consultation, like we talked about, mental health. We have begun using or depending heavily on scheduling appointments, as we did for the vaccination and others, for chronic care consultation. And similarly, countries reporting barriers to utilizing these strategies where there was limited access to limited access to telehealth strategies or for patient and providers, or limited organizational or technical capacities. So again, this is a learning process. And so from round 1 to round 2, countries began to move and change and grow. So I will stop there, and I will conclude by saying the magnitude and the extent of the disruption in the provision of essential health services persists in most cases, and they have increased in some instances. And it is necessary to guarantee that any COVID-19 strategy is balanced with other health priorities. And we found in the Bahamas that we had to say, hey, people are still suffering from NCDs, people still have other communicable diseases. We have to pivot, we have to make sure we continue the services. And so my final slide is just to remind all of you that the world is indeed at a critical juncture. The execution of our forward-looking strategy must include NCDs for us to build back better. Thank you and have a good night. Any questions?
Dr. Thompson, thank you so much. And it was so impactful to see how we share so many similar experiences with other countries,
Yeah.
particularly other Caribbean countries.
Yep.
So thank you so much. Are there any questions from the other attendees?
Dr. Hood-Burroughs, Dr. Frankson here. Could I ask a question?
Yes, sir.
Thank you for sharing it so gracefully, and thank you, Dr. Thompson, for very enlightening presentation. Doesn't make the situation any better that so many were suffering so well. But just a little comparison near to home, just down at the bottom of our archipelago, Turks and Caicos Islands, which I think you also have charge over as well.
Yes, sir.
How did they do?
They did, at the beginning of the pandemic, they did two things we didn't do. They had, or rather we didn't have access to, for one, Public Health England would have come in to assist them. So they had an increase in their public health workforce. So there was a contingent of Public Health England individuals, as well as they would have outsourced or brought in a number of Cuban health workforce to beef up their staff complement. So in the Bahamas, we started this whole conversation having significant limitation in the number of nurses and the number of certain doctors. And so we started off at a loss. And so we asked of our healthcare workers significant, I mean, you guys did a yeoman's job in staying on the wards, staying at the wheel and continuing to work. And we have round 1 and round 2 and round, okay. And so you continue, but there was no replacement. So Turks and Caicos they augmented their health workforce, one, and then they augmented their health services workforce, they augmented their public health workforce, and then they had access to, as a UK territory, they had access to the vaccines before we did, significantly before we did. And so the British government would have gone ahead and said, if you have one, there's mandatory testing. 2, if you're working in this country and you have a work permit, you have to be vaccinated. And so the conditions in the Turks and Caicos was somewhat different from us. And so they were able to vaccinate quicker. They had augmentation of their workforce. And so they suffered as we did, but not to the extent that we did. They have a younger population. The epidemiological profile for the Turks and Caicos is probably similar to the Bahamas, but they haven't done any of the nationally represented surveys to say what the true disease burden is. And so they have reported fewer deaths, although it was significant for their small numbers. Does that answer your question?
Yes, ma'am, and I suspect that their economy is rebounding quite nicely.
It is rebounding quite nicely. Their cruise, they should now have cruises. I was able to visit in midsummer of this year, let's say July, and the tourists were everywhere. When Nassau, downtown Nassau was still closed. And so, you know, they, like I said, they were able to rebound quicker than we did.
Thank you very much.
Dr. Thompson, there is a question in the chat asking, how will Ministry of Health be able to use this information to improve its services moving forward?
So the individuals who would have responded to this survey would have been the focal points in the Ministry of Health. And so the result of this survey is something that the PAHO and the World Health Organization is sitting at the table discussing with the various ministries of health to talk about how we should build back better and what that means in terms of, you know, re-engaging with our elective surgeries, rebounding for our outpatient services, and trying to work with our public to let them know that, you know what, yeah, there's a risk of catching COVID at your health center, but if you wear the mask and you behave appropriately, you will be fine. And so this information is being used to drive a lot of those newer policies around, you have to keep the services open. We have to think about how we make that happen and how we provide services for our public. The ministry is currently working their way through the implementation of the HEARTS project, which is standardized treatment guidelines for the NCD, the 4 big NCD diseases. And one of the areas that the ministry is seeking to look at is strengthening telehealth capacity, where we have individuals taking some control of their health, looking at their blood sugar, looking at their blood pressure, and having that being transmitted back to the doctor. And so we get a better sense for what type of control is happening, you know, in the home, as opposed to waiting until the person has a stroke or something and have to come to the accident emergency. And so they're working their way through a number of projects to try to strengthen what's being done in country. Over.
Once again, Dr. Thompson, thank you very much. We're very grateful for this presentation that you gave this evening. Thank you very much.
Thank you much for having me. Good night.
Good night. Moving on to our next presentation, we will have another resident presentation. Our next presentation is coming from another member of the Department of Medicine, a recent graduate from the DM program and now a senior member of our department, Dr. Nicholas De La Roda. He will be presenting hospital-based prevalence and ecological and therapeutic correlates of heart failure in patients admitted to the Princess Margaret Hospital. We are very grateful for this presentation from Dr. De La Roda, who has contributed so significantly to our department, and so we look forward to hearing his presentation. Dr. De La Roda.
Hi, good
Thank
night.
you.
Thank you. 1 second. We can see the slides and hear me clearly?
Yes, we can.
Okay, thank you. All right, so good night again. As she said, and I appreciate it, Dr. Hunt, I'm Dr. Nicholas Steele Larota, and coming from the Department of Internal Medicine, I'll be presenting my DM research project on hospital-based prevalence and etiological and therapeutic correlates of heart failure in patients admitted to the Princess Margaret Hospital. This is outline for today, background, objectives, methods, results, and then our conclusion. I don't have any disclosures currently at this time. So heart failure is not a clinical disease, but a constellation of symptoms, which are the manifestation of cardiac dysfunction. It is progressive and has significant morbidity and mortality. And without any adequate intervention, many patients will succumb to their cardiac dysfunction. Cases of heart failure around the world are on the rise. And in the Western world, the prevalence of heart failure is reported to be about 1 to 2%. And the incidence approaches about 5 to 10 per 1,000 persons per year. Perusal of the literature revealed a significant lack of heart failure-related studies in the Afro-Caribbean population, which is an apt description of the population of the Bahamas. And currently, there is no formal study that delves into the epidemiologic characteristics of the heart failure population in our country. And because of this, there is no clear idea of the actual prevalence of the disease, and there's no data on its associated etiologies and characteristics of the disease in our population. However, according to the Statistics Department at the Princess Margaret Hospital, there have been over 700 heart failure-related hospitalizations between 2006 and 2014. So therefore, to understand how the numbers of heart failure-related admissions and readmissions can be decreased, it was necessary to first assess the prevalence, etiology, and current management practices that we have here in our country. So the objectives of the study were to, 1, determine the prevalence of heart failure in patients admitted to the Department of Internal Medicine at the Princess Margaret Hospital, to establish the most common etiologies of heart failure in the Bahamas, 3, to ascertain which associated comorbidities are present in the heart failure population, and to illustrate whether these patients are maximally medically managed. So how we went about it was that we produced a retrospective and prospective cohort study, which was single-centered, all taking place at the Princess Margaret Hospital. It included 90 participants with a diagnosis of heart failure. And this population for the study were all persons who met the inclusion criteria and were admitted to the Department of Internal Medicine and PMH between July 1st of 2019 and October 31st of 2020. With regards to the inclusion and exclusion criteria, they had to be 18 years or older, admitted to the hospital within that specific allotted period of time, consent to the questionnaires, either from the patient or the relative, be able to give a coherent interview and meet the Framingham Heart Study criteria for heart failure. And those who were excluded were those that could not or did not give consent, and those who just chose not to be a part of the study. As I mentioned, the data itself was collected using a researcher-prepared questionnaire. This questionnaire sought to evaluate factors including participant demographics, personal medical history, their lifestyle practices, factors surrounding their heart failure diagnosis as well. Beyond that, participant medical records were also reviewed for their history of heart failure admissions, medications, interventions, electrocardiogram, and echocardiogram results as well. And between the two of these, this is how it became a retrospective as well as a prospective study. The data was then collected and transferred to the current version of IBM SPSS for statistical analysis of the data, providing those values that were significant statistically. So moving on to our results, the average of the projected number of admissions for the years 2019 and 2020 were used as a denominator to determine the prevalence of heart failure admissions to the Princess Margaret Hospital during the study period. And what we found was that with the 90 participants that we had diagnosed with heart failure, the prevalence came out to be about 0.65%, with a 95% confidence interval of 0.6 to 0.7%. Just to look at some of the demographic data that we also were able to collect, the participants in this study were more likely to be Bahamian. Looking at this first graph, we see that 94.4% was the amount of Bahamians in the study. More likely to be males at 62.2%. They were mostly of African descent. There was only one person in the study that was of Caucasian ethnicity. They had a mean age of 60.6 years, and they were more likely to be residing in the Baines and Grantstown area. Here we see at 17.2% on this bar chart, and reside on the island of the Providence, as we see here, a majority at 78.3% were from the Providence compared to the other islands. Some more demographic data that we were able to achieve. When we saw that participants' median highest educational level completed was that of obtaining a high school diploma, here represented at 68.5%. Yet most were actually still unemployed at 68.5% as well. And we saw that they were likely to be maintaining a household income of less than $25,000 per annum, here seen at 42.3% on this bar chart. So just to cover some more of the objectives that we wanted to pursue, here we have depicted the amount of the comorbidities that were associated in this population, as well as the etiologies of heart failure in our patient population. So the first chart here looked at the comorbidities, and we can see that hypertension stands out significantly compared to the other comorbidities, coming in at 87.8%, followed up by diabetes at 41.1%. The other two major ones were chronic kidney disease and CVA, or cerebrovascular accident, which were just around 20%. We had an other category as well, coming in just under 25%. And this category was left for persons to state other comorbidities that they had that wasn't listed in the questionnaire. So this included things like atrial fibrillation, myocarditis, pulmonary embolism, peripheral vascular disease, carotid stenosis, COPD, etc. Then we had down here our heart failure etiologies. Once again, hypertension led the pack in terms of singular etiologies at 32.6%. This information, once again, was gathered from the questionnaire, so it was left to the patient to tell us what they understood the etiology of their heart failure to be. And we saw what significantly stood out as well was that just under 40% did not even know what was the cause of their heart failure. We could talk about it later in the discussion, but that stood out pretty significantly. So some of the history with regards to symptomatology and echocardiogram, we were able to classify the patient into several groups. So using the New York Heart Association classification, the majority of our patients fell into the stage 3 class. So this would be persons that would have symptoms with minimal exertion compared to the other stages. When looking at the American College of Cardiology and the American Heart Association classification, a whopping 95.2% fell into class C, which would mean that they have either current or prior symptoms of heart failure with cardiac morphology changes, with the rest of them landing in class D, where they would require interventions. But this is expected because patients wouldn't come to hospital unless they have symptoms at the time of being seen. And then lastly, we were able to look at the ejection fraction data from the echo types into reduced ejection fraction, mid-range ejection fraction, and preserved ejection fraction. And the majority of our patients fell into the preserved ejection fraction category at 44%. So in rounding out the objectives that we are trying to achieve, we wanted to also find out whether or not these patients were maximally medically managed. So this bar chart here was able to depict the different medications that the patients were taking and the amount of patients that were actually on each of these types of drugs. So the one that led the pack here was the loop diuretics at 58.9%. We also had beta blockers coming in at 30%. ACE and ARB were just above and below, putting them together, it'd be just around 40% because patients are either going to be on one or the other and not both at the same time. And then we had aldosterone antagonists coming in at 22%. Also significant on this chart, once again, is the population of patients that did not know what medications that they were taking. Just about a third, just over a third, or just under a third, sorry, not knowing any medications that they were taking. So I think that was also still pretty significant. What we also asked patients was about whether or not they were compliant. And so out of the 85 persons that were able to provide a response for that question, 47 of them admitted to being compliant to their medications. And so that gave us a compliance rate of about 55%. Now, this also included persons that said that they didn't know what medications they were taking. So we had to kind of take that with a grain of salt, if I'm being honest. So in conclusion, the prevalence of heart failure in patients admitted to the Princess Margaret Hospital in Providence in the Bahamas was found to be appreciable, yet less than the prevalence of other regions. We saw that this value that we got of 0.65% falls short of the average amount of heart failure hospitalizations in the US, depicted in the American Heart Association Council on Epidemiology, who ascribed 1 to 2% as the prevalence across their country. What we also noticed was that heart failure with preserved ejection fraction was the most prevalent type, while hypertension was the most common underlying etiology and comorbidity. This is in keeping with the fact that hypertension is the most common cause of preserved ejection fraction heart failure, but also in looking at some other studies, a small study out of Jamaica, the Heart Institute of the Caribbean there, they also found that hypertension was a most common cause and underlying comorbidity in their population, quoting numbers as high as 68%. Also, there was a study called the Global Burden of Disease study, where they noted that 2/3 of all cases of heart failure were attributed to 4 different conditions, hypertension being one of them, but also your ischemic heart disease, COPD, and rheumatic heart disease as well. So this is still in keeping with what we are seeing here in our study. And one last point to make with regards to this section is that previous studies done in the Black populace suggest that heart failure is likely to be caused by coronary artery disease. It's less likely to be caused by coronary artery disease, but more likely to be caused by hypertensive heart disease, which is once again in keeping with what we saw here. And it wasn't a significant amount, but we saw that the most commonly used drugs in our population were that of first-line heart failure therapy in the form of loop diuretics, ACE inhibitors or ARB use, as well as beta blocker use. And looking at the treatment guidelines from the American College of Cardiology, these are some of the first-line options. They were recently updated, actually this year, to include your angiotensin receptor neprilysin inhibitors. However, still, these 3 main drug categories are still top tier in terms of first-line treatment. So for us, it was difficult to know whether the patients in the study were maximally medically managed because we didn't really look at each patient separately based on their class of disease and so forth. We weren't able to make inferences that possibly persons with HFpEF or heart failure with preserved ejection fraction were possibly covered because the amount of persons on loop diuretics exceeded the amount of persons that had the condition with preserved ejection fraction. When it came to the persons with reduced ejection fraction, we didn't think they were quite maximally medically managed because even though the amount of ACE, ARB use and loop diuretic use exceeded the amount of persons with reduced ejection fraction, those persons were also not being covered with beta blockers and aldosterone antagonists. So we felt like this population wasn't quite covered. But that's something that we'd have to pursue and further study, as well as reviewing our data properly to see if that's possible to bring forth. So just final acknowledgements. I wanted to acknowledge Dr. Dames, who was instrumental in the formation of the proposal, study design, and construction of the thesis. Dr. Frankson provided an abundance of statistical support and guidance in the development of the results and discussion sections of the thesis. Public Hospital Authority, who allowed the study to be conducted in their institution, as well as the study participants who, without any of them, the study would have no merit. These are my references, and thank you.
Thank you, Dr. LaRoda, for an excellent and very thorough presentation. Do we have any questions at this time for Dr. De La Roda? Dr. Frankson, I see your hand is raised.
Yeah, just a little comment. to Dr. De La Rosa. First of all, it was such a pleasure working with you.
Thank you, sir.
You are, I have to say, you're the most focused doctor I've ever worked with. You were like a laser focus. But sometimes we could get pretty noisy in the unit. There's so many of us there. But you survived and you're shining. Just one little thing I would say, that when you're reporting the prevalence, I would say report it per 1,000 rather than percent.
Okay.
That would be like 6.5 per 1,000.
Yes.
And then the confidence interval would be 5 per 1,000 to 7 per 1,000. Okay, that's all I have to say.
I appreciate it, sir.
Okay.
Dr. Philippe?
Yes, thanks so much. Dr. La Rosa, awesome. This is great information as you are establishing the data in our country, and that's really significant. If we're going to move ahead, we need to know where we're starting. Now that you have this data, what are some of the key recommendations that you have for, one, improving the awareness level of your patients? Because I noted that several of them, you said, didn't know the names of their medication. They didn't know what the disease was about. What do you think were some of those reasons why they were not as knowledgeable? And what are your recommendations for improving the knowledge of the patients? And will you do the study after you've done the intervention to determine if indeed the intervention that is needed works in our country?
Right. Thank you very much for the question. So I did look at it and thought about exactly what could be done to address this issue. And definitely patient education was a thing that came up as a potential source for resolution. I think it always starts at the doctor-patient level. So persons that are incumbent upon us, that we explain to them exactly what's going on with them, why they have heart failure. If we could determine the etiology, let them know what's causing their heart failure and addressing that as a possible source for worsening diseases over time. So if they could address that, then that could kind of help to keep their heart failure under control. But also, like I say, when it comes to medications, letting them know how important the medications are. Without taking them, it would be decreasing their morbidity and mortality. Trying to have a discourse where they could kind of ask questions and feel comfortable asking questions and understanding why the medications are very important to their disease process. And then beyond that, just beyond the hospital level or the patient-doctor interaction, then you always have the wider scope in terms of policies, having these medications always available for the patients to collect from pharmacies, especially persons that we mentioned in our study, a lot having not that much income with regards to the home, as well as not being, not educated beyond high school level and not being employed. So we have to make them available because it's just going to cause the situation to get worse. And then beyond just the education aspect, then we have to address the chronic non-communicable diseases that we mentioned in the previous presentation. These are going to lead to patients developing heart failure and chronic disease process associated with it. So we could address that, prevent the disease from developing in the first place. I think we'll have a better outcome overall.
Wow, thank you so much. And what do you think of the training for physicians? Because as you know, family medicine physicians and general physicians, in part of our training, do we have the quality of training for physicians to truly have the quality of communication that is needed for patients with chronic diseases? Or is there a need for health educators to be in our system to ensure that, you know, after the patient comes out of the clinic with you, there's someone they can really spend the time? What are your thoughts on that?
I believe the basic aspects are there in terms of learning, just basic from medical school, learning communication skills. Always, once you've studied that material, you're able to kind of communicate it better. But there's always a need for refresher courses, if you will. So you might have done that previously, learn how to communicate, learn the disease process, but having it retaught, or even in a forum like this where it could be reviewed on how to communicate and communicate effectively with patients, is something that could always be provided and addressed. So that would be my recommendation with regards to that aspect. Thank you.
Thank you, Dr. De La Rosa. And we certainly have been informed by your research. Thank you so much.
Thank you very much. Have a good night.
We will now go to our next presentation, our next resident paper. And so our next presentation will be by Dr. Susanna Brzozog. And her presentation will be Laparoscopic Colectomy for Colonic Neoplasms, the Bahamas Experience. Dr. Brzozog is a recent graduate of St. George's University. She is an aspiring surgeon with an interest in research, medical missions, and reconstructive surgery. She currently works at Bahamas Plastic Surgery, and we welcome her with her presentation this evening.
Thank you. I'm just getting everything sorted. All right. Good evening, everyone. It's a pleasure to present my research on laparoscopic colectomy for colonic neoplasms in the Bahamas. We have nothing to disclose. This is the outline for this evening's presentation. So introduction, background, clinical objective, methods, results, discussion, and conclusion. According to the Bahamas National Cancer Registry, colorectal cancer is the third leading cause of cancer in the Bahamas overall, and it is the second leading cause of cancer in both males and females, following prostate and breast respectively. In 2018, the incidence rate was reported to be 18.9 per 100,000, and in 2019, it increased to 21.3 per 100,000. Multiple randomized control trials have demonstrated the safety and oncologic equivalence of laparoscopic colectomy over open colectomy in the management of colorectal cancer. The first successful laparoscopic resection of a villus adenoma was performed in 1991, and this led to laparoscopic colectomy becoming the preferred method for colon cancer resection worldwide. In 2009, the first successful laparoscopic colectomy was performed in the Bahamas for a resection of an adenoma. The benefits of laparoscopic surgery include decreased postoperative pain, faster return of bowel function, faster return of functional status, shorter length of stay, better cosmetic outcome, minimal bowel handling, and a lower systemic inflammatory response. The aim of our study was to review demographics, treatments, and outcomes of patients with colorectal cancer who were treated with laparoscopic colectomies in the Bahamas over a 10-year period. We assessed the disease pattern and the distribution within the colon, the recurrence rate, the survival rate, and any predictors that may impact clinical outcomes. Our study design was a retrospective review of a prospectively held database. We reviewed 57 patients who underwent laparoscopic colectomy between June 2011 and June 2021. We compiled a database that was kept in an Excel spreadsheet, and the statistical analysis was performed using SPSS software version 27. The inclusion criteria for our cohort was that the patient either had a biopsy-proven diagnosis of colorectal cancer or they had a clinical presentation of colorectal cancer. The exclusion criteria for our study included any laparoscopic colectomy that was performed for any condition other than colorectal cancer, and 6 patients underwent the laparoscopic colectomy for diverticular disease, 2 for ulcerative colitis, 1 for endometriosis, and 1 for schwannoma. So this led to 10 patients being excluded, leaving us with 47 patients in our cohort. What were our results? We looked at gender, age, ASA scores, and BMI, and compared these baseline characteristics. Of note, 55.3% of cases were in women, and 87.2% of cases were in patients greater than the age of 50. The most common ASA scores were both 2 and 3, and the median BMI was 27.5. Our tumor distribution showed that the majority of the colorectal cancers occurred in the right colon, followed by the sigmoid. This is a breakdown of the surgical procedures performed, with 42.6% of the cases being right hemicolectomies, which is in keeping with the data seen on the previous slide. The data for our surgical outcomes showed that there were 3 conversions, a median duration of 243.5 minutes, a mean estimated blood loss of 100 mils, and a median length of stay of 4 days. Our pathological data showed that the most common stage was stage 3, which was 34% of the cases, and the most common pathology was adenocarcinoma at 74.4%. And of the 35 cases of adenocarcinoma, 31 were moderately differentiated. All procedures were R0 resections, and the median tumor size was 4 centimeters, and the median retrieved lymph nodes was 15. For ease of analysis, we separated our cohort into 3 groups: right, left, and rectal, which is on the next slide. The right was defined as cecum to distal transverse colon, and the left was defined as descending colon to sigmoid. We then reviewed various parameters of the right and left to determine if there were any statistically significant differences in outcome. The variables reviewed were age, BMI, conversion, duration, estimated blood loss, tumor size, the nodes retrieved, and length of stay. The duration was the only variable that was statistically significant, as it showed that the duration of the left-sided procedures was greater. And this is in keeping with standard practice. These are the surgical outcomes for the rectal cases. Of note, there were 0 conversions, although the rectal cases were longer than both the right and the left at 377.3 minutes. The data for the post-operative complications showed that there were 3 early complications that occurred within the first 30 days post-operatively, and that there were also 3 late complications that occurred following that period. The complications were then classified using the Clavien-Dindo classification. There were 3 major complications in total, which were all ventral hernias, and they occurred all in the right-sided procedure, and they were all late complications. There were 3 minor complications, with 1 occurring on the right side, and that was a small bowel obstruction, and 2 of the minor complications occurred on the left, which was a wound infection and deep vein thrombosis. We use the Kaplan-Meier method to estimate survival. The mean survival rate at 5 years was 62%, and we did not achieve median survival time. We also ran a multivariate regression analysis to determine predictors that influence survival. The predictors analyzed were length of stay, conversion, duration, estimated blood loss, stage of disease, and recurrence. We found that recurrence was the only statistically significant predictor of survival. The data for our tumor recurrence revealed a tumor recurrence rate of 17%, with 12.8% of the recurrences occurring systemically, either to lung, liver, or both lung and liver. And the time to recurrence, or the median time to recurrence, was 12 months. Here we compared our data to the laparoscopic colectomy arm of the major randomized controlled trials for laparoscopic colectomy in colonic neoplasms. We looked at several measures, which were the conversion rate, the duration, the mean estimated blood loss, length of stay, and the early complication rate. We compared favorably in all parameters. Of note, our length of stay was shorter, and our conversion and early complication rates were also less, although you can see that our duration for the procedures was longer. We also looked at the positive margin rate, the mean lymph nodes retrieved, the port site recurrence rate, the recurrence rate, time to recurrence, and the overall survival rate. Once again, our data compared favorably, noting that our positive margin rate and our port site recurrence rate were both 0, and our mean lymph nodes retrieved was greater. The limitations of our study include retrospective bias and the number of patients in our cohort. In conclusion, laparoscopic colectomy is the standard of care for the surgical management of colorectal cancer. This procedure can be carried out safely in the Bahamas with minimal morbidity and acceptable outcomes. These are my references. Thank you.
Thank you, Dr. Broussard. Are there any questions?
That's an excellent presentation. I just looking at your conclusion when you said that this was the standard of care, or would you say that this is another option of care? Because there are quite a number of countries, I'm pretty certain. In fact, if you were to look at the data just in the Bahamas, what percentage of colectomies for malignancy, what percentage of, how much do you think your numbers would be compared to the total amount overall? Do you say that it is 10%, 20%, 40%, 50%?
Hi, Dr. Roberts. I'm not exactly certain of the percentage, but just to clarify with the conclusion, laparoscopic colectomy as compared to open colectomy is the standard of care for the surgical management of colorectal cancers.
I was just questioning whether that's a very hard statement to say. When you have, I'm pretty certain, more than half of the colectomies done for malignancies in this country are not done laparoscopically. So you're saying that more than half of our surgeons are not practicing the standard of care? Are you saying that in places like Jamaica and Barbados and Trinidad, where I'm pretty certain that the majority of surgeons who are board certified, that they are still doing open colectomy, that you're saying they're not practicing the standard of care?
No, I'm not saying that because you have to also look at the reasons why the patient may be a better candidate for open colectomy. So it's up to the judgment of the surgeon to decide if the patient is a better candidate for laparoscopic or open colectomy.
I was just pulling your leg, noting that the only procedure that I am aware of from a laparoscopic point of view, where the standard of care, where laparoscopic procedure is the way where even an insurance company would have second guess as to whether they would pay for it, is cholecystectomy. Okay.
I understand.
So I'm just saying that is a very strong statement to say that it is the standard of care. It is what
I understand, but just to follow up with my statement, that comes with the backing of all the other research studies that have been conducted. So there is the COST trial in the United States and Canada, and also the COLOR trial in Europe, the ACLACS trial in Australia and New Zealand, and the Barcelona trial. And they all said that they all came to this conclusion. And the purpose of the presentation was also to present our data for the laparoscopic colectomies to say that we are also on par with the laparoscopic colectomies done on an international scale.
I said, I accept your answer. I'm just saying that's an indictment on our surgeons to say that we are not doing the standard of care. That's all I wanted to say.
Thank you.
Madam Chair, if you may let the epidemiologists and ethicists come into this one. Standard of care is a very flexible thing. It depends upon what is standard of care for me to treat somebody who is hit down on a car accident down on the road to Adelaide. It's a different thing from standard of care when that person reaches to the emergency room. So standard of care is very context driven. And if your country is one where you, economically, etc., you can do better. Your standard of care requirement is different from one like at one of the countries you called, where they're struggling with their economy much worse than this country is. So that might help in seeing how these things are being recommended as standard of care.
Good evening.
Good evening. I see that Dr. Ward has his hand raised. Good evening, Dr. Ward.
Good evening, Dr. Hunt-Burroughs. Just to follow up on the statement, first of all, I'd like to congratulate the speaker on an excellent presentation, but the word standard of care has legal implications. And I would just like to say that many litigations are won when physicians fall below what is considered a standard of care. So like what Dr. Robin Roberts said, it's a very strong statement, and I would perhaps say change it to the desired care for colon cancer, laparoscopic. Because you see, every country is different, and I know we read journals from first world countries, a lot of research is done in first world countries, but remember the resources vary across countries. So if you have, say, a 55, 60-year-old surgeon who graduated very long time ago and didn't do laparoscopic surgery, and he's still doing colonic cancer surgery, you can't really say he's falling below the standard of care. So the term has connotations and legal implications. So I would say that we need to bear in mind our resources, and as the epidemiologist said, Dr. Frankson said, it has to be contextual when we're talking about care for patients. And this is across the board in medicine, because a lot of strong statements are made in these first world journals. But remember, it depends on your resources. So don't get caught up with that, because the lawyers, once they see that, and if you say that as an expert, then you might be inadvertently indicting some of your colleagues. And that is why Dr. Robin asks, what percentage of colonic cancers are done laparoscopically and open? Are all of them done laparoscopically? I doubt it. But I mean, it's a debate that we have to consider. Thank you.
Thank you.
I think while we are in the atmosphere of Research Day, however, we want to encourage persons to always be aware of where the research is leading And while we are in a clinical context, we then encourage and nurture their application of the clinical context to their research. Are there any further questions or comments for Dr. Berzagzov? Dr. Francis, yeah, I see that your hand is raised.
Yes, thanks for a great presentation, by the way. I have one question and then a comment. Was there a reason why all of the late complications, the hernias, done on the right side? Were there any complications of hernia on the left, and why not?
Thank you for your question, Dr. Francis. There were no late complications of hernia on the left. And the reason being, I'm trying to recall, it's because of the way that the technicality of the laparoscopic surgery on the right. And usually you can expect a hernia to be a complication, if I said that correctly.
Yeah, well, it's brought out periumbilically, and sometimes it's difficult to close that incision. Whereas on the left, it's brought out like a fan and steel incision, and the hernia rate for that is really, well, practically zero.
Yes.
But I also want to say, I mean, yeah, we could debate the standard of care thing, right? Great debate. But I think worldwide and the randomized control trials that she has shown, yes, in more resource-rich environments, it is the standard of care. But yet, yes, we can debate in a resource-poor environment where you don't have that, or somewhere where laparoscopy is not available. Open colectomy is still an option. But I think all of the randomized control data, which is level 1 data, albeit done in more first world countries, does state that laparoscopic colectomy is standard of care in the management of these colonic neoplasms. So just to put that out there.
Once again, Dr. Berzagzov, thank you very much for an interesting and informative presentation. Thank you very much.
Thank you.
And now we will move on to our keynote presentation. Our keynote speaker is by no means a stranger. He is familiar to all of us. Dr. Nakia Forbes is the director of the National HIV/AIDS Program in the Bahamas. She is the director of the National HIV/AIDS and Infectious Diseases Program at the Bahamas Ministry of Health. She is a consultant in infectious diseases at the Princess Margaret Hospital and Doctors Hospital, and she is a member of the lecturer staff at the School of Clinical Medicine and Research. She is also herself a graduate of the University DM program. And at this time, Dr. Forbes will be presenting for us today updates on COVID-19 in the pandemic and in the Bahamas and future directions. And so at this time, we welcome Dr. Nakia Forbes.
Thank you, Dr. Hunt Burrows, and thank you to the organizers for inviting me to present on this topic. I'm going to share my screen now. And can you confirm that you're seeing my screen?
Yes, we can see.
And so tonight I will be talking about the updates on the COVID-19 pandemic in the Bahamas and where are we going with this pandemic? What is our future outlook going to be? I have no financial disclosures or conflicts of interest. And my presentation will be in two parts. In part one, I will talk about our local situation and the updates here in the Bahamas. And in the second part, I will focus in on future directions. I'm going to talk about breakthrough infections, countries where there were problems with vaccinated persons, having breakthrough infections, emerging variants, and the implications for us in our world and our country. I'm going to talk a bit about clinical COVID-19 and updates that we know about in terms of the clinical presentation and the sequelae. I'm going to update on treatment. Quite a lot has changed from since the last time we had our COVID-19 University of the West Indies School of Clinical Medicine and Research COVID Symposium. And there are some prevention updates as well. And I will also talk about what's in the pipeline in terms of research on what makes some people susceptible for COVID-19 and what might be accounting or causing some people to have asymptomatic SARS-CoV infection versus people who are critically ill. And what lessons did we learn from the pandemic here in the Bahamas? And so, as we've been hearing throughout our research week, SARS-CoV-2 is the name of the virus that caused a global pandemic that really started in December of 2019 when we first heard of this novel coronavirus, and it quickly became a global pandemic and a healthcare emergency of international concern. As of today's date, there have been 221 countries that have reported a case. And globally, as of October 27th, there have been 244.3 million cumulative lab confirmed cases worldwide, and 4.96 million people have died of COVID-19, making this the most deadly pandemic in the last 100 years. This has actually surpassed the number of deaths from the Spanish flu in the 1900s. Nationally, the first case of COVID-19 was announced on March 15th of 2020. And to the end of the week, October 25th of this year, we have had a total of 22,306 cumulative cases. 1,157 cases are active, meaning they haven't recovered from COVID-19 yet and are still infectious. In the hospital, there are 86 cases, and the hospitalized cases are distributed between the Princess Margaret Hospital, which has the majority of the hospitalizations at just over 50%, followed by Doctors Hospital across both campuses, the Rand Memorial Hospital and the South Beach Health Center, which was repurposed for a COVID care site. There have been 643 cumulative deaths to date, and the last percentage positivity rate at the end of the last epidemiological week that ended October 25th was 15%. So what is the situation around the Family Islands as it relates to the COVID-19 cases? In this table, you will see the total confirmed cases in terms of the cumulative count by island. And you will see that New Providence makes up 76.3% of those cases, followed by Grand Bahama with 11.3%. And then you can see that throughout the other Family Islands, there have been reports of cases, with Abaco and Eleuthera having roughly around 650 cases. And there have also been clusters of COVID-19 cases in various Family Islands at various times, including Bimini, Crooked Island recently, and the other islands. The map of the Bahamas shows the active COVID-19 cases at the end of October 23rd. And you'll see that there were about 1,069 in Nassau and 48 in Grand Bahama. Eleuthera had 45 cases, and those were the islands with the top 3 number of cases. And there are other islands who have single digits, including Inagua, which came out of a cluster, which had 5 active cases at the end of the last epidemiological week. So here in this graph, we can see the number of incident and cumulative COVID-19 cases by specimen collection date, as per the Bahamas Ministry of Health. And this shows the cases since the start of the outbreak. So please note that the first wave was quite small now in retrospect. And that started in March of 2020. And that there was a decline in these cases to a very low baseline. One day there was only one case, and that wave indeed ended. Then we had a second larger wave that started in July of 2020. And you can see that that wave also had a sustained decrease over a number of weeks. That stayed relatively constant until the third wave began here in about March of 2021. Now, if you will note, there has been no sustained decrease over weeks in this third wave. And so the third wave is indeed actually continuing, and there were ebbs and flows in this third wave, that there was a low point here, but cases again surged, and they are now starting to decline again, fortunately. So it is possible to take the epidemiological curve and overlay certain things. It's possible to overlay significant things that may have happened, and also restrictions and interventions that may have been put in place in an effort to flatten the curve. And so this is what this graphic shows. So here is the epidemiological curve that we just looked at. And as you can see here in the orange, I've overlaid some key things that may have happened. And so we had border reopening right about here at what is called epidemiological week 23. That correlates to about July 1st. And then a summer period where there is a series of a number of holidays and weekends. You will also see that in the time period that we had the first wave in March, immediately that first week, we had a 24-hour curfew. And as a matter of fact, Dr. Thompson showed a picture of no cars being on the street, and only essential staff were allowed to leave home. There were also travel restrictions and border closure, virtual school, and there was a government quarantine facility and isolation facility. And that may have caused this wave to be flattened significantly with a sustained decrease in the number of cases. In the summer period, there is a cluster of holidays, and we did not have a 24-hour curfew in the second wave, but we did have night restrictions and enhanced crowd mitigation. That may have contributed to the decline in the second wave. This is when the vaccines rolled out. Now, keep in mind, it takes time for a large proportion of the population to develop immunity, but that is the date that the vaccines rolled out. We also found here that it was announced that circulating strains of variant COVID-19 were identified in the Bahamas with a Delta predominance, but all the other strains that were sampled were also variant strains that are more infectious. And that happened in this period here. And again, we went into the summer travel holiday period, and it was an attempt to have earlier night restrictions. And then this is the period that was the polling day, and the dissolution of Parliament was around here. And so you can look at the epidemiological curve and try and analyze it and see if any interventions made any sort of a difference, or were there any key notable things that may have impacted these waves. As we know, the socialization and poor public health compliance may impact and increase the spike of COVID-19 in country. And it certainly gets harder when there's a lot of COVID-19 in the community and community spread. This is the breakdown of the COVID-19 cases by sex at birth. And we can see that in terms of the cumulative cases, females made up 53% of the cumulative cases and males made up 47%. And then when we looked at the case distribution by waves, that was almost 50-50. Well, females made up 51% of the cases in wave 1 and in wave 2 as well. And they account for 55% of the cases in wave 3. This is the age distribution of the cumulative COVID-19 cases. And please note that the majority of cases are in the age group 30 to 39 years of age, followed by 20 to 29 years of age and 40 to 49 years of age. And certainly there are fewer pediatric cases. The curve of deaths really does follow the epidemic curve in this virus. And so you can see the waves of COVID-19 here on this slide as per the WHO, with waves 1, 2, and 3. And you will see that wave 3 has been the deadliest wave, with the majority of deaths occurring when indeed there was the highest spike and surges of COVID-19 in the country. When we look at the distribution of deaths by sex and age group, females make up about 50, just about 50.5% of the deaths, and males 49.5%. And when we look at the age distribution of those that have died, the majority of cases are in the 40 to 64-year-old age group, followed by the over 65 age group. So where are we in terms of vaccinations in the Bahamas? We rolled out vaccinations. The pilot actually started on March 16th. And to the date of October 16th, roughly 32% of the population have received 1 dose of the COVID-19 vaccine. And about 30% of the population are fully vaccinated. And so 1 or 2 doses of the vaccine were given in the recommended interval for those 2-dose vaccines. And perhaps this was the correct decision, because we know that having only 1 dose does make persons at risk for having breakthrough infections. And we have recently received a delivery of the Pfizer vaccine so that more persons will be able to be vaccinated. And we have heard, and we thought it very, very important to have local data that would reflect our experience with COVID-19 hospitalizations and what was the vaccination status and deaths among persons that were admitted with severe COVID and whom had died, to have a local experience to correlate with what was happening and what was being reported in international spaces. And so we have heard that 95% of hospitalizations and deaths were unvaccinated persons, with a smaller percent, between 2 to 3%, being partially vaccinated, and 1 to 2% are just over being fully vaccinated. And where are we in terms of the world statistics with vaccination? About half of the world has had 1 vaccine or more, and 39% are fully vaccinated as of this morning. Well, we know that variants can make vaccines somewhat less effective compared to the original strain. And so we do know that there are variants in country, and the Bahamas Ministry of Health, the reference lab, reported on a sample, a select sample of patients that had been sampled between May 6th and August 8th in the Bahamas. And this is what was found. Of those samples, and 81 were analyzed, 51% of those samples were positive for the Delta strain of COVID, and 48% were the Alpha strain, and 1% were the Gamma strain. What does that mean? All of those are variant strains of COVID-19, and they're all so-called variants of concern. So when it comes to the genetic lineages of SARS-CoV-2 that are emerging and circulating, there's a classification that there are various terms: variants of concern, variants of interest, variants of particular interest. But a variant of concern is worse for treatments, vaccines. They may be more transmissible. They may also be more transmissible at even a faster rate. And Alpha, Beta, Delta, and Gamma are examples of those variants. So Delta is twice as transmittable as other variants. Antibodies and vaccines are less effective. Alpha is more transmittable, and Gamma, the vaccines, are less effective. And currently at this time, the National Reference Lab sends out those samples for phylogenetic and genetic testing. So that is where we are in terms of the update of COVID-19 here in our Bahamas. And I'm going to now move into part 2 of our presentation, which is what does the pandemic future look like for COVID-19 in the Bahamas and indeed worldwide. So this is what the world's epidemiological curve looks like. And you can see that it also has waves. And at this point, if you know that there are 242 million cumulative cases and many more active cases and cases per day, that what is your strategy? Can you eliminate COVID-19? It's highly unlikely, and countries have tried. So for example, New Zealand did try to eliminate COVID-19, and they did very well for some time. There was 0 cases. They really enjoyed many freedoms. However, what becomes clear is that when you do have reopening, that COVID-19 will resurge. And that's exactly what's been happening in New Zealand recently. And so there's a lesson here in that COVID-19, that elimination is highly unlikely. This is not the only virus of its kind. SARS coronavirus, the first one, and MERS coronavirus were also coronaviruses that were novel at those times, 2003 and 2012 respectively. But they were eliminated. They were eliminated from the planet. They maybe were not as fit, but it appears as if COVID-19 will be here for some time and that it will indeed be seasonal. In the context of vaccinations, 3.86 billion people have received a dose of a COVID vaccine, but that means that many people are still unvaccinated, almost 50%, and that means that they are at risk. And that also means that there is a risk for emerging variants. And at this time, there's a variant that has been identified in about 53 countries called the Delta Plus, Delta AY2. And it does appear that it may be more transmittable, but it is being studied. It's not really circulating in any large scale at this time. And so scientists are studying that. And so we do have to be concerned that with the epidemic still happening, that that is fertile ground for variant emergence. Other strategies. So is the strategy instead better if you look at protecting the health services? And the key then would be putting in place mitigating steps to keep the cases low and below the capacity of the health system so that there isn't too much pressure to the health system, so that COVID care can be delivered to save lives and in order to prevent the diversion of services away from usual care. And as Dr. Thompson alluded to, that means that usual care, cancer care, and chronic non-communicable diseases may not be getting the attention. And so there are already consequences from that. And then there's disease control. There have to be modalities to be put into place to mitigate severe COVID-19 and deaths, and that is going to get to be critically important. So that's exactly what the future is going to look like. Elimination, highly unlikely, and how do you put in place strategies and strengthen your available services like contact tracing, testing, early testing, and other interventions to try and give us a chance with this epidemic. I'm going to talk now about breakthrough infections. And this is really a hot topic because we hear every day, and there's a lot of information that there can be breakthrough infections. And there have also been reports of countries that are seeing breakthrough infections and high numbers of COVID-19 infections, including in people who have been vaccinated. And this has to be understood and scientifically studied and analyzed so that we can learn lessons from this. And without doing this, it does create opportunities for misinformation, further mistrust, and this thing called COVID pessimism, which is now a new term, where people are convinced that COVID is not going to go away and that there isn't going to be viable solutions. And so I'm going to spend the next part of the presentation talking about some of these things that have happened and how we should interpret it and the lessons that we should learn from it, and what does this mean for our future outlook. And so one such report was in the Morbidity and Mortality Weekly Report. And this reported an outbreak of SARS-CoV-2 infections, including breakthrough infections in people who had been vaccinated associated with large public health gatherings. And this was in Massachusetts in July of 2021. And essentially, there were 469 cases of COVID-19. It's apparently a huge summer weekend where there are a lot of parties and gatherings and reunions. And in this community, vaccine coverage was actually about 69%. However, there was an outbreak associated with this weekend and these events, and approximately 74% of those cases occurred in fully vaccinated persons. And when they looked at the genetics of the viral strain, 89% were the Delta virus and 1% was Delta plus. Now, 79% of the vaccinated persons who got COVID were symptomatic, and 5 persons were hospitalized, and 4 of those persons were fully vaccinated. There were no deaths reported. And this was really the first large outbreak like this that was reported in the United States. And it made people ask, just what is happening here and what was the recommendations and take home. And so it became clear that even if you were vaccinated, if you're not following the public health precautions, if there are indoor gatherings, for example, and a mix of persons, including persons who've recently traveled, vaccinated and unvaccinated, there is a potential for COVID to spread. And so the recommendation from the CDC MMWR was that all persons, even the fully vaccinated, should wear masks indoors and in public settings, especially in areas where COVID-19 transmission risk is high or substantial. And it even further suggested that in jurisdictions without substantial or high COVID transmission, consider expanding prevention strategies, such as good adherence to mask wearing and other public health measures, such as mitigating large gatherings. So that is what happened there in that case. And then we hear a lot about Israel and the fact that Israel was very, very quick out of the gate to start their vaccination strategy and to get a number of persons vaccinated and have good vaccine coverage. However, there became a report that persons who were vaccinated were indeed having breakthrough infections. And so let's talk a bit about that. So 80% of eligible citizens were vaccinated very early in the summer, June of 2021. And when we say eligible citizens, at that time, it was persons who were 16 years of age and above. That made up about 68% of the total population. What happened was that the country then lifted movement restrictions and mask mandates, and it went very much back to normal pre-COVID movement and behavior. The Delta variant arrived in June of 2021, and then COVID case numbers started to climb in September of 2021. And then it was noted that about 60% of hospital admissions in mid-August had 2 doses of the Pfizer vaccine. But this had to be studied and looked into closer. And so there was a sub-analysis of this. And so what they did was they looked at vaccine efficacy and they broke it up into certain things like people who had medical comorbidities and age groups and a vaccine period. And that's what's reflected here in this graph. And so they looked at, this is the over 65 age group. This is 42. This is the over 60 age group. This is 40 to 59. This is below that age. This is the younger age group. And this is when vaccines rolled out. And so just like here, the vaccines had been prioritized to those that were most vulnerable, people with medical conditions and older people at first. And that's what this black bar is here. So those over 60 got the vaccines first. And so you'll see that there are no persons who were able to get vaccines here. That's why these bars are actually essentially white, because they weren't eligible at that time. But as time went on, you will see that the persons who got the vaccines first over a 5-month period were more likely to present to the hospital having been fully vaccinated with breakthrough cases. And that was less likely in those who got the vaccine later, like 2 months prior to the study date, for example. And this did not bear out in the younger age groups. And so that made them interpret the data as the persons who were 60 years and older, especially those with comorbidities, are more likely to have breakthrough infections and end up being hospitalized and dying, hence the recommendation to put in the booster in Israel. And that does support the booster for the Pfizer vaccine in any event. So it actually does support that when you look at the age-adjusted numbers for vaccination, the chance of hospitalization for those greater than 60 years reduced 40-fold if you're vaccinated compared to unvaccinated, however. But they did implement a booster program, and that does appear to be bearing fruit, because just last week they reported a very, very low COVID-19 positivity rate of below 1% for the first time ever, and a reduction in hospitalizations. And so as a follow-up, there is this study in the New England Journal of Medicine that suggests that fully vaccinated persons 16 years of age or older, at least 12 days after the booster, their rate of infection was lower in the booster group than the non-booster group by a factor of 11.3, and the rate of severe illness was lower by a factor of 19.5 in the Israel studies related to COVID-19. Now that's Pfizer, but what about the AstraZeneca experience? So Public Health England also has a publication that looks at the protection against hospitalization, and it's much higher and holds up well, although there are some signs of waning with AstraZeneca and Pfizer for the elderly. So you can see here that over time, when we look at the antibody levels, they're declining somewhat, especially over age 80. It's also going down a bit here to about 80%, and somewhat less for younger persons. This is also true in those who have underlying health conditions. So you can see here that there's waning, and that would make persons clinically extremely vulnerable if the efficacy, this is the AstraZeneca vaccine, would fall to about 60%, or even this is about 70%, but you can see that that's less pronounced in the younger age group. And the protection from death holds up well for both vaccines and across age groups from young to old. Now, what does this mean? It is safe to get a booster dose, but it is still being medically looked at. And the data is still out in terms of AstraZeneca and Moderna. There's a half-strength dose. Johnson & Johnson, there is going to be a booster dose for that about 2 months after getting the first dose, which may imply that that should have been a 2-dose vaccine. And those are things that are in the pipeline. So vaccines, what may it look like? They may be changing over time. Additional booster doses may need to be given, and something about the vaccines and the coverage for variants may change over time. Also, the way that vaccines are given, we can expect that to change in the future. Some will continue to be intramuscular, but there may be other modes of delivery. For example, nasal vaccines. There's a study that will support that mucosal immunity may be better with the nasal vaccines. And so it may somewhat protect you better in terms of inhalation of droplets, for example, if you're exposed to COVID-19. Now, the CDC has a very, very large study where they're looking at the breakthrough experience, and of more than 189 million people who received the COVID-19 vaccine in the United States. They have looked at the reported breakthroughs. That accounts for about 41,000 cases, which is very, very uncommon. The rate of having a breakthrough infection would actually be way less than 1%, about 0.02%. But this is ongoing and will continue to be done. We're in the process of gathering that data for the Bahamas. The CDC has a compilation of studies that they released on September 10th, and that summarized that for persons who are unvaccinated face much greater risks from COVID-19 than vaccinated persons. They're 4.5 times more likely to become infected, 10.5 times more likely to be hospitalized, and 11 times more likely to die of COVID-19. And in the United Kingdom, the risk of breakthrough infections in this study by Antonelli and et al. Indicated the risk of breakthrough infection was 0.02%, and the risk of long COVID-19 was 50% lower than unvaccinated persons. I'm going to move on now to the future and what does clinical COVID look like? Well, we've come a long way in terms of knowing about this new virus, and there are a number of sequelae that can happen. People can get myocarditis, pulmonary fibrosis, diabetes can be en masse. They can actually present with debut diabetes mellitus. There can even be fungal infections. But there is a sequelae that is called long COVID or post-COVID-19 or long hauler syndrome. And there's a definition for this. It's new, returning, or ongoing health problems that people can experience 4 or more weeks after first being infected with the virus that causes COVID-19, as per the CDC definition. And this actually makes up to 30% of persons after COVID. They can complain of this problem. It's not a small problem. It's turning out to be quite large. Almost 1/3 of people who get COVID may end up having long COVID. The pathophysiology is being studied, but there are a lot of postulations. It could be direct viral toxicity, endothelial damage, the immune system is dysregulated, a hyperinflammatory state, or sequelae of critical illness, but there's a myriad of symptoms. And some of them are very, very vague. They can include tachycardia, confusion, memory loss, fatigue, something called brain fog, cognitive dysfunction, worsening of psychiatric conditions, anxiety and depression, breathlessness, feeling feverish, for example. And these symptoms can change over time and the recovery time varies. And it's also very frustrating for patients because a lot of people do not believe that they're actually feeling these things and discard it. And so it has been recognized in the infectious disease world that people will be dissatisfied and feel marginalized and minimized when they present with these symptoms, but they really do feel unwell. There's no diagnostic test to say that this is what they're having. It's guided by symptoms, and there's imaging and other tests like pulmonary function tests, cardiac tilt table testing, etc., that is guided as per specialist recommendations. And there's no cure for it yet. It is actually a patient-centered holistic approach that's going to need treatment partnerships, and functional improvements may help with that multi-specialty addressing of this condition. And vaccination may help in up to 50%, but these patients are going to need support. And so in our future outlook, we're going to have to build and expand programs to be able to support such patients. And we're also discussing that. I don't have much time left, but since our last research day, there have been some updates on therapeutics. So the last time we spoke, we basically had corticosteroids and an antiviral called remdesivir. But there are some new kids on the block. For example, the IL-6 antagonists that are repurposed rheumatoid arthritis drugs they seem to be helpful. There's a trend to reducing mortality, and also patients do seem to have greater clinical improvement at 28 days when they are on some of these medicines. And then we also have neutralizing antibodies that were not available the last time we had our COVID symposium. And they have two roles. They can be for post-exposure prophylaxis in people who are at high risk for getting severe COVID and they have been exposed, they're COVID negative, meaning, or they can be used for ambulatory care patients who already have COVID-19, but are at high risk for decompensating. And so there's some criteria for that, essentially. So for prophylaxis, it largely is for people who have a pre-existing medical problem that would put them at risk. And it can be helpful for those not fully vaccinated, but that's not absolute, because there are people who are fully vaccinated that will not mount an immune response. For example, persons with malignancies or on immunosuppressive medications. So of the persons who received this drug, which is actually Regeneron, that's the trade name for it, there was a relative risk reduction by 81% in those people who received this drug for post-exposure prophylaxis. It also can be given for treatment, but that's for ambulatory patients with mild to moderate disease who are at high risk for severe disease. And the criteria for who's at high risk are those who are older age, for example, more than 65, obese or overweight, pregnancy, chronic kidney disease, diabetes, immunosuppressive therapy, cardiovascular disease, sickle cell disease, neurodevelopmental disorders, for example. And this may help significantly. There was an absolute mortality reduction of 1.9% and no deaths seen in the study arm compared to placebo, and a lower relative risk of hospitalizations and a faster clearance of viral load, essentially. Now, what's to know about this? This is not a substitute for vaccination. It's better to not get COVID in the first place. And when we think about the global public health good, vaccinations are free and safe and effective and very available versus this therapy, which is about $3,000 a vial. So it's not really a good viable comparison. In the pipeline, there are other medicines that are being studied. For example, a drug called molnupiravir. It's an oral antiviral treatment for COVID-19, and it's very promising. It's in phase 3 trials, and essentially it is for eligible outpatients who have SARS-CoV-2 infection. And if you take this within 7 days, and it's administered twice daily for 5 days, at day 5, there was increased viral clearance in all of the patients, and the risk of hospitalization and death was cut by 50%. And so it is still being studied, but if it does become available, it definitely will change the game for persons who have COVID. And the great thing about this is it will be able to be produced at a very, very cost-effective price. And the manufacturers have already promised that the patent will be shared, and there's already mechanisms being developed for how this is going to be able to be manufactured and shared as a global public health good. My last slide in terms of our future outlook is the genetic basis of coronavirus disease. And when I started out, some people are asymptomatic, other people die from COVID. And there are a number of things that may be contributing to that. Gender, blood group, HLA, genetics, ethnic groups, geographic backgrounds, we don't know. And so there is a movement to understand the causal relationships between host genetic basis and COVID-19, and to see if there are biomarkers for individuals at high risk. And that would then drive potential targets for therapy, a drug curative effect, identify at-risk persons, and effectively control disease. And so there are large data consortiums that are organizing to study this, and we hope to be involved in such research. So we will update you on that as it progresses. So what did we learn? What's the way forward? What's the future outlook? COVID-19, it's not likely to be eliminated or eradicated. Strategies need to protect the health system and prevent surges in cases and to prevent deaths. Vaccines are effective to reduce infections, hospitalizations, and deaths. Breakthrough infections may occur. And it's critically important to combine vaccination strategies and following public health measures, especially universal mask wearing in public places and indoors. Variants are a threat and will continue to emerge, especially in the context of insufficient vaccination coverage. And as time emerges, in the pandemic outlook, more is becoming known about manifestations of the disease, including long COVID. The treatment options have increased with clinical trials on newer antivirals, reporting promising results. And more is to be learned as it relates to mechanisms of disease severity and genetics. However, research does thrive in the COVID-19 pandemic in the Bahamas. Thank you for asking me to share this presentation with you, and we look forward to sharing more of our work in terms of the outbreak here in the Bahamas. Thank you.
Dr. Forbes, thank you for a very informative and comprehensive and interesting presentation. You always seem to find a way to help us to distill a whole lot of information in ways that we can make it useful. And so we want to thank you. I really appreciate what you've done in this amount of time with so much information. Do we have any questions at this time for Dr. Forbes? Dr. Cooper, I see that your hand is raised.
Hi, good evening. Can you hear me?
Yes.
Excellent presentation, Dr. Forbes, as usual. The CDC website recommends a booster shot in people 50 to 64 years old that have medical conditions. And some of those conditions are diabetes, cardiovascular disease, including hypertension, and obesity with a BMI greater than 25. Does the Bahamas intend, which is probably half of our population in that age group, do we intend to offer booster shots to that population as recommended by the CDC?
That's a great question. And yes, we're going to have to do that at the right point. But there is an ethical dilemma, and I always try and remember fairness as it relates to accessibility to healthcare and doing the best for all, essentially, and healthcare for all. And so in our context, we don't have an unlimited quantity of vaccines at this time. And indeed, only 32% of our population has been vaccinated. And so there are other conversations. For example, the WHO has pointed out that even when we look at vaccines as a global public health good, half of the world has not been vaccinated. And that when we think about giving boosters, is it fair to boost when there are vulnerable people, some of them in frontline positions that have not received the vaccine to date? And there's a little more to it, because we know that COVID, it's still a global pandemic, and that in that context, variants are happening, and variants break through existing vaccines. And would it not be a strategy to get a dose of vaccine to everybody would cut down COVID significantly, hence maybe needing less boosters or new vaccines, you see? So it is a little bit of a complicated issue. Now, there are people who are super immune to COVID. I couldn't talk about everything in the time frame. If you had COVID and had a vaccine, you are super immune, apparently. And so we have to weigh that in terms of when they can be introduced. Yes, we're going to see that happen, but we have to strategically plan it so that there's sufficient vaccination coverage so that it's fair first. And I would say to you that of all the countries in the world, this is still somewhat an experiment, and countries are still having to decide for themselves. For example, there were countries that of the doses they had, they decided to give everybody 1 dose. Versus we didn't do that. We gave the 2-dose series as soon as possible when you're eligible. And what does that mean, right? Because in partially vaccinated persons, there's some protection, but not as much as we saw in our data slide with the vaccination experience, that partially vaccinated persons are also vulnerable. And so it is a little difficult to navigate, but to answer your question as simply as possible, yes, I think we'll get to the point where we're giving boosters, especially to vulnerable persons. But there probably will be a little time before then, because we need to increase vaccination coverage somewhat before then.
Thank you. Dr. Roberts, then Dr. Thompson, and then Dr. Barrett.
Good night. Excellent presentation. A great overview. Compliments to you, Dr. Forbes. I noted, though, in your talk, you didn't mention much about herd immunity. Can one make the case that in the Bahamas, noting the fact that we are decreasing the number of new cases that we see and decreasing our hospitalization, can one make the case that what we have is as many more people are being vaccinated, and the fact that we have a high prevalence of COVID-19 in the community, could we then say that the combination of the high prevalence, people being infected asymptomatically, and the vaccine, that what we actually seeing now are decrease in cases being herd immunity?
That's a great question, Dr. Roberts. So here's the principle. Let's start with the principle of herd immunity. That's the percentage whereby expert consensus says if you have that amount of your population immune, you won't be in clear and present danger, basically. There'll be so little COVID, so little people that COVID could actually infect. But that's actually about 80%, 70 to 80%. So we're a ways off from there. Even if you add the people who got COVID that were lab confirmed to the number that were fully immunized, we would still be quite a ways away from that statistic. Some people think that herd immunity, that 80% number, is going to be extremely hard to achieve for the world. Given vaccine hesitancy, pessimism, and newer variants, that is starting to get to be a destination that is harder to reach than we thought. But there are things that are contributing to the cases going down. And I could go back to the epidemiological curve, but a part of that is vaccinations. And a part of that is us coming out of the surge that we had and other factors that related to that surge. And overall, with an increased number of persons being vaccinated, there are less people that are susceptible. So I think that is starting to bear out. But herd immunity, we're gonna have to see. We'll have to see if we can get there, if the world can get there.
Thank you. Dr. Thompson?
I wanted to add to the conversation around vaccine equity. And so as we see the larger countries or the wealthier countries giving boosters, it now presents a challenge for smaller countries like us or those with less resources, because if you recall, there's a lot of us that benefited from donations. And so as the larger countries began introducing their booster, the availability or the supplies will be less available for us to get donations. And so adding to Dr. Forbes's conversation or her response, we can find ourselves, the rest of the world can find themselves in more jeopardy because the access to the vaccines will dwindle as the larger countries continue to push towards boosters. So that's just a thought for the group to keep in mind. Good night.
Thank you. Dr. Barrett? Is Dr. Barrett still on? Dr. Frankson, I saw your hand raised.
I expected an excellent presentation this evening, and I was nowhere near disappointed. It was really, as you said, Dr. Hunt-Burrows, just really what we needed. I see that Dr. Bassett and I are thinking the same thing, so Dr. Bassett, if you permit me, I'll ask the question for you. What about the children? Is that even on the radar screen for us in light of all that you have said? And the second thing is just a comment that it looks like this disease is actually involving every specialty. And now there is, what did you call it? COVID, this and psychiatry's. It looks like it will be inviting psychiatry to come in to join the team as well. And I know that psychiatry is actually residents are doing several research projects related. That's why you can look forward to next year's research day when all of those get presented. But just what's it with the children? And you can ignore my last comment, but let's see if I'm right with time.
So vaccines, Pfizer is having an EUA, and the eligible population is going to be younger, 5 to 11 years of age. And I think that is actually rolling out in the US this week. And so what is the information? It's that children can get COVID. They could spread COVID. Some of them, sadly, some children will even die from COVID. We don't know why some do fine and some die, because healthy children can die from COVID too. And we need to try and figure that out, really, why some people are fine and some people are not fine. It seems overall from the global experience that if a child gets COVID, they seem to be okay and be able to recover. As you saw when I presented the number of cases and the deaths, that it was low in the pediatric group. But there's a little more to it than that, because children can get COVID and they can spread it. And what I didn't present in my presentation is that there's an economic and health fallout from COVID, an economic and social and education fallout is what I meant to say. And that the Minister of Education said in the media this week that 30% of children are not in school or not accessing school here in the Bahamas. And so when they go back to school face to face, which is needed, there can be COVID. And there were spikes when school opened in August in the US in children. And there were some other school COVID studies that suggested that the adolescent group too, because of their activities after school, that there could be a spike in COVID cases, and then they can spread it to vulnerable people like teachers, parents, grandparents, and so on. And so that it could be good to vaccinate because it will add to the pool of less people who are vulnerable and able to spread COVID. I would think that that is reasonable, that those points are reasonable to support vaccination in that age group.
Dr. Hunt Burrows.
Good evening, Dr. Barrett.
Yes, sorry, I was unable to unmute earlier. It said the host didn't allow me, but I'm on now.
Oh, apologies. That might not be me, but I'm glad that you're here now.
Okay, thank you. Dr. Forbes, brilliant and thorough presentation. In relation to the reality of mutation of all viruses, we know that viruses actually can mutate within hours. So you can have different strains in one person over a period of hours. Is it possible that SARS-CoV-2 can mutate itself into neutrality?
So COVID mutates like any other virus.
Right.
And when it makes a mistake, that's what it is. It makes a replication mistake. When it does that, that sometimes confers nothing. Sometimes it doesn't confer disease, it doesn't confer resistance, it doesn't confer transmissibility, but sometimes it does. So that's the problem. Right. Yeah. And so I didn't want to take too much time in the presentation because it was so hard to try and highlight what future outlooks what I would talk about. But there are other variants. There are variants of interest that the scientists look and say, oh, this could be something that's important. It could really be harder to treat. And then there are variants that are of no consequence at all. They don't do anything bad.
Thank you. May I add to the comment about psychiatry that Dr. Frankson made? Please, Dr. Burrows.
Yes, please.
Okay. From the very beginning, psychiatry was involved, and we're seeing more now. Dr. Forbes mentioned about fog and related to something called alien cells. But we have seen all the variety of psychiatric sequelae in COVID patients. I've treated quite a few myself, and it is estimated, according to research, that 20% of people who got infected with COVID-19 are going to have some significant psychiatric sequelae. So psychiatry should be at the table right now.
Amen.
Thank you, Dr. Barrett. Dr. Forbes, there is a question in the chat that asks, with regard to vaccines, if an individual has had the first dose of the AstraZeneca vaccine and the second dose of Pfizer vaccine, would that individual be considered fully vaccinated? And would you recommend a second dose of either vaccine as a booster?
Yes, that person would be considered fully vaccinated. And there are studies that suggest that with the mixing of vaccines, that the immunity might be better in terms of the antibody level that could be measured. And if they were going to get a booster, then they could get another vaccine. They could get either one of those other vaccines However, the data is not quite in yet on AstraZeneca and when that booster will need to be. It's being studied. But Pfizer, there's already a clear indication, at least in the United States, and it is being boosted already in Israel.
Thank you. I see Dr. Philippe, your hand is raised.
Yeah, thank you so much, Dr. Forbes. That was definitely an amazing learning experience. Excellent. I wanted to talk about the long haul COVID, and you mentioned the sequelae of the brain fog. Two questions. One, has that been seen in young people and young adults? And two, recognizing the long haul, how do you think it's going to transform the public health service and system? Because as you know, right now, people, you're saying that clients will come in and describe this, and now as a public health physician, you have to determine, did they have COVID? Is this real? How much time to give them? And how will this impact the productivity of the public health service? What policies do we need to start to put in place? How do we need to really change the way we are providing the service, recognizing that this will make a significant impact?
Yeah, that's a great question. So we have to put in place systems to care for these patients, and it has to be multi-sectorial. And there has to be a way of screening these patients, and it's great that it has a definition. Because even acute COVID, a week or two afterward, people can still have a lot of those symptoms: breathlessness, feeling tired, that they can't think, fatigue. Some patients can't even get out of bed. And so we have to provide the support mechanisms. And how this is shaping up is long haul clinics in some places. And there are actually studies going on, like in Washington, DC, there's some studies on long haul, and people have already put in place support services. But like I said, it has to be multi-specialty, and it has to involve psychiatry, ID, public health, internal medicine, pulmonology, cardiology. It really depends a lot on the symptomatology the patient has, and more support, psychology, occupational health, could be physiotherapy. It really, really depends on what symptoms the patient is feeling. But a word of caution here: some of these symptoms are vague. Like they can have something like the POTS syndrome, where they just feel tachycardia, lethargy, weakness when they stand, for example. And it's more common in females, and especially highly functional individuals, in one study in Washington, DC. And people were reporting dissatisfaction because when they reported having these symptoms, people didn't believe it. They didn't think that there's nothing objectifiable. There's no test or anything. And so we do, and it can happen in up to 30% of patients who get COVID. So we do need to put support mechanisms in place. We're going to have to think that through, because there are going to be a lot of people who are affected with this, and the recovery time can vary. Some of these patients can have this for months, 10 months, 8 months. Vaccination can help. It can reduce symptoms, and 50% of symptoms of patients, their symptoms improve significantly or go away after vaccination.
Dr. Forbes, question for you. For those individuals who would not have been previously vaccinated prior to having the natural infection, any comments on how many doses of the vaccine they should receive?
I'm still in the standard dosing regimen, but it's just that people who did get COVID are super immune, but the recommendation is don't try and get COVID and then get vaccinated. It's still in the usual vaccine series. There are some people though, right, that won't mount on measurable response. Not that you're supposed to try and measure a response, but think of someone with a blood cancer, for example, or on chemotherapy, for example. They may not actually become immune after vaccination. So that's where you need to start thinking about boosters and so on.
These are some of the questions that people ask. So I see 2 hands raised, and these will be the final questions before we bring the session to a close. Dr. Moxie, and then Dr. Van Turen.
Yes, good evening, everyone. Great talk, Dr. Forbes. My question is a straightforward one. It's on the J&J vaccine. Are there any plans to have the second booster given? And why I'm asking that, how would you prepare the public for that? Because they're going to say, see, they don't know what they're doing again. They said we only needed one, and now they're saying we need two. I'm just talking in the colloquial Bahamian, you know, because there's so much, you know, mixed messaging going on out there that, first of all, are we going to have it, or are we going to give it? And then how are you going to get around the messaging to convince people who thought they were just going to need one shot to come back for their second shot?
Yeah, that's a great question. So first, let me say that COVID-19 is a new virus. And so the only way to know about it is to study it and have objective data. And that's what actually the largest compilation of scientific data and active scientific research is going on right now for this very same virus. It's never happened like this before. So there is a lot of data in the searchable space. And that's how we have to look at this. We have to be objective and say, okay, we had vaccinations that was supposed to help significantly. We're seeing that there can be breakthroughs. We're seeing the need for boosters, but you have to try very hard to communicate objectively and from a place of understanding. So in new outbreak viruses, the human condition is we blame people, we have mistrust, we have disbelief, and false information. That is just the way it is. And we're called as doctors to get to know the facts and to study the experience to say, what do we make of this? What does this mean? How do we regroup? Is there a lesson that we can learn here? And for example, Israel, we when we studied it, we realized, okay, several things. You can't discard the public health measures with vaccination. You need good mask wearing. And who got in the hospital? 65-year-olds, some period out from when they got their vaccine. And so hence the recommendation came, do not forget about the public health measures. Everyone has to be adherent to mask wearing, and boosters may be needed for vulnerable people. And so you just have to try to humbly understand where people come from, because there is a reason for vaccine hesitancy, mistrust. It's deep rooted. And there was injustice that happened in healthcare systems and studies and other things. That really happened. It wasn't unfounded. And you just have to speak the facts and study it. Johnson & Johnson, it's not in practice yet that we're going to need a second dose. It's looking so. The CDC and the FDA are discussing that. Johnson & Johnson, quite probably the US has the highest number of people with it. And so it's being studied. You know, it didn't roll out until, you know, just the end of last year, was it? And so we have to see what will be the experience. And, you know, they're looking at, for example, the curve of patients that are presenting who got what vaccine. And so when you have new scientific information, you pivot and you, I hate that word, but, you know, that's what you have to do. You have to incorporate updated data to update the science. And that's all you can do when you try to just present it neutrally. Now, in the face of that, you're going to experience hesitancy and vaccine and COVID pessimism. And that's not a term I made up. That's actually a real term. That people want this pandemic to be over. They want to go back to the way it was before. They don't want to hear anything else about COVID. That's actually being studied. So you just have to keep trying to wear away at it.
Okay, we are at the limits of time. Last question, Dr. Van Turen.
Hello, can you hear me?
Hi, Dr.
Yes, we can.
Oh, because I'm calling from London, and I was very keen to hear all the questions. Unfortunately, the time difference, I missed a lot of your lecture, your talk earlier on. Anyway, there was mention about the long COVID or long haulers. And I think quite a while back, I might have seen one or two, but I'm seeing more and more recently obviously, Dr. Forbes, there's no specific answer to that from what you are answering the question earlier on. In fact, I was watching a TV program here last week after another conference from Nassau by Francis. And straight away, I saw this program about long haulers, and it's becoming quite I think they're doing a lot of work on it. In fact, they have a sort of a society or what you call group, and that has become bigger and bigger. And then I saw some coming from the States as well, that in England, there's about over 1 million long haulers, but I think there's even much more than that. And their most common complaint I hear from all the people talking about it, you interviewing long haulers, is fatigue, brain fog, and they still haven't got any way of dealing with it. Have you heard any way they're dealing with that to begin with?
Yeah, that's exactly the challenge with long haulers. There's no cure for it. It's not like you can take a course of antibiotics and then it's over. So how it's dealt with is a multi-sectoral team and specialist driven. If the patient has something like a POTS syndrome, the cardiologist, if they're cancer bed, the physiatrist, for example. And so it's going to be challenging, and we need to know more about it. And scientists are looking at it to see if there will be a blood test we can do, for example, but it's going to be a big problem.
There was a question about someone asking, saying, do you think the COVID might also cause reinfection, what's the word I want, coming back again, of maybe your Epstein-Barr virus is surfacing up again, could be some other virus that might surface, just like HIV. When you get it, all the CMV comes up, you got all the weird infections that you never see on, let's say, an immunocompetent person. That's one anyway. Number two, you were mentioning about AstraZeneca and mixed vax, what they call COVAX or COMVAX. And I see a lot of people in London here, colleagues of mine, are getting 2 different shots, and they seem to have good antibody response. In fact, one of my patients in Nassau, when he's staying in England for a long time, I say, get your vaccination and then get your COVID test. Now, are you doing the I was mentioning the MAB, I saw the other day something about COVID antibody, doing the quantitative form. Is that being done a lot in Nassau or not?
Okay, so a couple questions there. Yes, it's okay to mix vaccines. The immune response might be even bigger. COVID, it's new, but it is already making certain infections come to light, like mucormycosis is happening as a sequelae of COVID, especially in India. They had reported that. I don't know if it could cause EBV to flare, but at least one patient who has chronic EBV told me that they feel horrible again after getting COVID, and they were okay before that happened. So at least that's one anecdotal report, but I haven't heard a lot of other experiences with that, and I haven't seen it in the literature. And then the antibody levels. Now, antibody levels are not diagnostic in any kind of capacity. You should never tell a patient, let's see if you had COVID and do an antibody level to see if you need to be vaccinated. It's wrong. So antibody levels, they may have a role for surveillance, serosurveillance, for example. But we have to remember too that it's a very research specific thing. And even when antibody levels are measured, immunity is more than just the antibody level. There's a T and B cell response and memory B cells. And so I don't encourage in clinical practice antibody levels. We are out of time. It's 9 o'clock.
She said, I sure am.
Yes. And so once again, Dr. Forbes, with much gratitude, I want to thank you for a very interesting, very informative presentation, and for, of course, raising the level of our insight into this pandemic and the challenges that it would have presented for us. But nevertheless, for the learning curve that it also has given us. And so I want to thank you for making it seem so interesting for us tonight, and for speaking to us once again. And please do come again. As we draw the night to a close, before the vote of thanks, is Dr. Ablack here in the meeting?
Yes, Dr. Hunt Burrows, I am still here. Thank you very much to all our speakers for really excellent presentations. And thank you, Dr. Forbes, for helping us figure out how we're going to navigate moving forward. So I am just here to remind everyone that bright and early at 8 a.m. in the morning, we will be continuing with our CME program. And we will have Dr. Mark Levitt, who is the chief for the Division of Colon and Pelvic Reconstruction and the program director for the Pediatric Fellowship at the Children's National Hospital. And he will be presenting on the topic constipation, a guide for the pediatrician and the surgeon. Thank you very much, Dr. Hunt Burrows, for allowing me to make that announcement. Good night, everyone. See you at 8 a.m.
And now to close this great learning experience at the fourth night, we will have Dr. Corinne Sinclair-Brown.
Thank you very much, Dr. Hunt Burrows. And yes, this is our 14th conference. And this was started by Professor Spencer and has continued and expanded under Dr. Robin Roberts' leadership. The commitment from our directors has borne fruit and paid off. RBC continued support must be acknowledged and celebrated. Special thanks to the entire research unit and research day planning committee led by Dr. Darren Halliday, but all the other lecturers, associate lecturers must also be congratulated for outstanding conference. Countless meetings have resulted in an excellent delivery. We must also extend special gratitude to our administrative and IT staff as well. We're still ironing out the kinks and adjusted this to a 4-day conference of evening presentations from 6 to 8 p.m. Despite COVID, we have delivered, and the audience must be applauded for diligently signing on each night. We actually counted about 100 by Zoom and another 100 by YouTube each night. Special thanks to our invited and expert speakers, with special thanks to Dr. Edwards, Griffith Bowe, Calais Philippe, Dr. Aurora, Williams Hamilton, our PAHO rep, Christy Boros from NHI, and Nikia Forbes, who was our last speaker. Our moderators tried very desperately to keep us on time. Dr. Francis Williams, Dr. Braham, Dr. Pinder, Butler, Knowles, and Dr. Hunt. Thank you very much. The quality of the speakers' presentation and the broad expanse of topics must be applauded. Representation was seen from residents in just about all of the specialties. Well done. Now, hopefully we'll see these projects proceed to being published. I have a special reminder for you to fill out the evaluations and to get your CMEs. See you all next year. Good night.
Wishing you Godspeed, glory. There will be mountains. Watch my God.